How are you? You're all very welcome back. And I hope you enjoyed your lunch. I think you want to enjoy it after our morning's work. Can I introduce our chairperson for the afternoon? Our chairperson is Anne-Marie Hoey. Anne-Marie is the Regional Director of Performance and Integration in Dublin North East as of last Monday, Anne-Marie told me. So we're delighted to have Anne-Marie for the afternoon, and I think it's great for you to meet Anne-Marie and Anne-Marie to meet you and see the amount of work and the amount of performance-related projects that are actually going on out there in the services. Anne-Marie's new role is actually really focusing on performance assessment within the HSE to ensure that services are meeting their services. I suppose the services agreed under the service level agreement, but the role will also be monitoring and assuring the performance of services with a key focus on quality. And I think that's where the work you're doing can enhance the role Anne-Marie's doing at regional level. So, Anne-Marie, thank you.
Good afternoon, everybody. Thanks very much to Etna for inviting me here today to share the afternoon session. It's my privilege to be here. I know from looking at the programme for this morning, it was a very interesting morning, and indeed the afternoon will be no different. There's a great variety of presentations this afternoon covering the areas of paediatrics, palliative care, older persons, acute care, and mental health. So the full range of services will be covered. So no opportunity for anybody to have an afternoon nap after the nice lunch. The levels of research that are being undertaken and the amount of research that is being presented today, for me, I suppose it shows just such a huge commitment from the staff working in the various nursing departments within the HSE services. To give the time and personal commitment to research, but also to give that invaluable contribution then to developing the services for the patients we serve. And the transferability of the learning is also a huge opportunity for each of you, and through the network then provided through Etna's department and her colleague departments. So we have about 5 or 6 presentations this afternoon, so I won't go on any further now. There will be an opportunity at the end of the presentations for some questions and answers, so we'll hold them until then. And I have been asked to remind everybody that there's an evaluation form in your pack, and if you should take just a couple of moments during the course of the afternoon to complete that, and in fairness to give the feedback to the people who put a lot of time and effort into organising the sessions today. So our first presentation this afternoon is from Suja, who is a registered general nurse in Temple Street Hospital. She's a registered general nurse, a registered children's nurse, and a registered nurse tutor. Suja has been working for 15 years at the nurse and paediatric healthcare settings, including neonatology, general paediatrics, metabolic, and endocrine. She's currently working in Temple Street Children's Hospital as a clinical audit and nursing research facilitator, and is also undertaking on a part-time basis a doctorate from University College in Dublin. The presentation this afternoon is entitled A Practical and Innovative Approach to Clinical Audit and Nursing Research in a Clinical Setting, which is promoted through the Nurse Research and Clinical Audit, and is intended to improve and sustain better quality, safety and outcomes for children's health. Thank you, Suja.
First of all, I would like to thank Etna and Linda for the invitation. Fantastic. And I'll be talking about my job role at the moment. So this is, today my talk is all about practical and innovative approach to clinical audit and nursing research in a clinical setting. Before I get into detail, I just want to talk about what I'm going to talk today. I'm a bit nervous though, only start. So I'll be talking about what is research and audit, because there's always people kind of find difficult to define what is research, what is audit. What's the importance of placing research and audit in a clinical setting, practical setting? What lesson we learned in the past, and Temple Street experience of placing research and clinical audit? What we do in Temple Street at the moment in terms of audit and research? So what is research and what is audit? Research, what is the right thing to do? And research always seeks new knowledge. When we think about research, there are different methodologies. We talk about qualitative, quantitative, phenomenology, quantitative, many more. But what is audit? Are we doing the right thing in the right way? Are we auditing our current practice against the best practice? That is real audit. If there is no standard exist, but still you can develop your local standard with the local consensus, then you audit your practice. And make sure you have an agreement with your stakeholders before you start your audit. Okay, why do we carry out audit and research? We heard from many speakers from this morning the importance of research, audit. We heard Francis' report, we heard many more. So I'm just going to go through why is important. Of course, this is going to improve the quality of service delivery parties provide. Always think about ourselves as a patient coming through the door of the hospital. What we expect? We expect quality. Quality of care is a simple expectation from anyone going to the hospital, and safety is bare minimum. This is going to protect the caregiver. We provide the care. We want to make sure we provide the best possible care for the children, family, and patient. Reflective learning, we learn from our own mistake, how we can improve our care. Or training, service quality improvement. There should be a constant improvement in the practice because things are changing all the time. Not just the IT. We have a new iPad, iPhone, but things in medicine always change. We need to keep up with the standard all the time. And this is from National Council of Nursing and Midwifery. Of course, the audit is going to improve the practice of nursing and midwifery, evaluate our own improvement by providing quality care for the patient. Definitely, we can contribute towards nursing and midwifery research. We heard many of the research this morning. How many people are doing the research in the practical setting? People doesn't want to come up here and talk. We need people like Linda, and I work for Temple Street. I know I'm only local, but we need many more people like Linda to go around, and people like me in every hospital. So that will help people come along and express themselves. Okay, we do this. They get the motivation. They get that confidence to talk. What lesson we learned from the past? We heard so many stuff. We heard about Bristol Inquiry. What is Bristol Inquiry? Anybody from the group? Some of you may have heard of this Bristol Inquiry. What is Bristol Inquiry? Yes, that's right. Yeah. In 1998, its independent investigation set to investigate 29 deaths of babies following cardiac surgery in a Bristol hospital. Yeah.
My niece was the last patient.
So today we are going to see how we can improve what we are going to learn from that inquiry, okay? So my focus is I'll be looking into more audit. So this inquiry set up in 1998 to investigate the death of the babies following cardiac surgery. And 529-page report came out after the investigation. And effectively provided blueprint for wide reform of NHS. That was the first report came out, and that really changed NHS, the way they provide the care and the way they looking after the patients. That was a blueprint report. And also, it lifted the lid on all the voice culture among doctors. And still, when you work in the clinical area, you know, still there is the culture. How do we change the culture? How we do proper work? It is very important because we are the frontline workers. We work with them. We need to have a collaborative partnership. At the same time, how do we work with them? The recommendation was audit should be part of the core system, local monitoring performance, and it should be supported by trust with the healthcare staff given time, support to undertake effective audit. When you go back and reflect this report with a escape recommendation, you will hear the protected time. I know we all so busy. We don't have the time to conduct your research. So that is another interesting fact things coming out from this report. And clinical audit should be compulsory for all healthcare professionals. When you look at the Medical Practice Act 2009, what is it telling there? All the doctors supposed to take, it is mandatory for all doctors to undertake clinical audit. 12 hours work of clinical audit to improve patient's care. And how many of the doctors are doing it at the moment? So my job at the moment, I'm like a hippo in the hospital, walking around asking people, did you finish your audit? What happened after audit? So we need people like me going around. So I didn't mean the wrong way, the good way. Report. And we had this morning Francis report. So imagine Bristol happened in 2001. This is 2013. The last year I was in Nottingham for a HQ conference. I heard so many stuff about Francis report. They spent billions of euros. Why? What happened in Francis mid-staff? Anyone know what happened in mid-staff? Anyone from the group? What is Francis inquiry?
1,200 elderly people died.
Not just a lot of patients. Needlessly died in 2 mid-staff NHS Trust hospitals. What happened? Just one little topic. I know just at the same time. In the ward, patients lay starving, thirsty, in solid bedcloth, and patient buses would drone endlessly unanswered. So imagine yourself in that situation. Nobody's there to mind you, and some of the patients have got a wrong medication. We don't want to happen that anywhere in the world. This is happening between 2005 and 9. Imagine, we are living in 21st century, still things are happening. So my interest, because I don't want to get into the detail of Francis report, anybody's interested, there's a lot of videos in YouTube, a lot of reports available. If you don't want to read the whole report, just go back and look in the YouTube video. Robert Francis talking about this report, 20 minutes worth video. Okay? So my interest, even though there was a clinical audit in place, what happened in mid-staff hospitals? There was no robust mechanism to ensure that changes were implemented. Even there was re-audit that often not undertaken. So audit always constant. It's never closed circle. It's a spiral constantly going. You have to make sure the re-audit implemented and the audit implemented, then the re-audit. Make sure that practice is sustained for a long time. Otherwise, what will happen? Best example, bank holiday weekend. We all drive very carefully. Why? The guards are out there watching me. Okay, by Tuesday, what will happen? Back to normal. So what we need a constant monitoring of our performance. Otherwise, things back to square one because we are human. When you listen to a Robert report in YouTube, the 4 things I thought very interesting. Lack of openness were there. Okay, people kind of blaming each other all the time. The lack of transparency of care they provided in mid-staff hospitals. Nobody knows what was going on. Because I was at the NHS conference last year, they were showing the building. Because CEO, Director of Nursing, the entrance were different from the main hospital entrance. So they didn't realize what exactly happening in the real setting. So we have to have an open communication. The hierarchy has to go. We all need to sit down together and discuss how we can change practice. We need to think, we all will be a patient one day. We will be in the situation. Who will mind you then? My son, I have a little boy, 6-year-old. Whenever I hear these stories, I always think me as a mother going to the hospital with my child. I don't want to hear these stories for my child. Same with the crumbling. They have put the wrong kidney, the big scan around. Do you think if your child, they remove the wrong kidney, coming to the media and telling, oh, we are really sorry. Do you accept anybody from the group? What do you think? You can't do that. It's your job to do. Make sure we do the job. That's a life. The life of my family, your family, everyone. The same. We are society. And I don't look like Irish, but I am. This one is, I know the goal where when you read the report, it's heartbreaking. But I don't want to get to the detail of the story, but I am interested in the HIQA report. Our investigation uncovered a series of failures in the management, governance, and delivery of service, not consistent with the best practice. What are we supposed to do? As a healthcare professional, it is our responsibility to make sure we are consistent with the best practice. How could you say that we are not consistent with the best practice? That's not good. Sorry, so my heart is talking, sorry. If I say anything wrong, please forgive me, but that's the way we need to think about it. This, we are dealing with the life of family, life of a husband, life of a child, life of a mother. We don't want to lose them. So always make sure we put ourselves into their shoes and think what we expect from the hospital. Then we talk to the real world. There are a lot of barriers to conduct original research. Lack of resource. Like if people like me or Linda will be there to support you, you feel there's no support, no funding. My own PhD, I do self-funded. When you prepare UCD, you think, oh my God, you have no fund. You know, it is hard. There's no fund out there at all to support current climate, current financial constraints, lack of skills. People in the clinical setting, they may not even heard of phenomenology. They don't even know what is descriptive statistics, what is its basis. So we need a person to support them. Okay, we are here to support you in terms of data analysis or design of the research, audit. They feel comfortable. People are working very hard in the front line, I have to say. Because I know my job changed, but I go to every day, everyone, I meet all my staff. It's not like I'm completely drawn from clinical practice. I know what is going on in ICU, I know what is going on in A&E. Insufficient time, another one. No time. We don't have protected time to do this kind of activity. If you're interested, you have to find a time. You bring literature review home, do it, weekend, this kind of stuff. My PhD starts in the night. Can you believe? 9 to 12 is my PhD time because I have no time to work. I work full time. My PhD is part time. So that's one of the examples I'm telling you. Still, the passion. You have to, have the passion to do this kind of work. So I'm here to motivate. I'm not here to demotivate anyone. Okay, I'm here to motivate people. Like the support, you have to have the organizational support. You have to have support from your colleagues to undertake audit or research in the clinical area. What will happen when you want to change something? Never happen. Because you are your own. You left out. If you have support from the organization, trust the management, your own department, everything will go smoothly. So now I'm going to talk about what we are doing at the moment in terms of research and audit. I will be talking about leadership and clinical governance, and a committee, resource, what publication output we have so far, and how challenging to implement the research in a practical setting. Okay, we heard this morning from Professor Anscott and I think that was Caroline Kavanagh. The effective leadership and robust governance system emerged as a critical in delivering high quality care. Of course, very important to have a good clinical governance structure in place. Because we are answerable, we are accountable for our own job. So if we have a good clinical governance in place, everything will go smoothly. So we have a department of research with a head of research, and director of nursing has a huge interest in research and audit. And we have a nursing research committee, and a few committee members are here, and I will talk about what we do as a committee. And we have a research coordinator, she is also a practice development coordinator, so we have a number of international studies, like a EPOC, Evaluation Patient Outcome, I just completed that study the other day. So we will be involved with another study called PINS, which is Pediatric International Study. So we are still waiting for the ethical approval. So that means we are engaging at the international level. I'm the local research associate for those studies, but we are engaging with a different number of projects. And that my job then is research facilitator. So committee, we have, I'm just giving an example how you could do in your own setting. Okay, it's not just ourselves, we are the best. No, we are not the best, we are still learning. So research committee is a group of nurses, including director of nursing. We have Veronica Lambert, Dr. Veronica Lambert from DCU, and clinical nurse specialists, managers, staff nurses, library. We all come together every month to discuss how we can promote and support nursing research in Temple Street. And we also champion the nurses to carry out audit and research. And we help them to implement this finding into real practice. And we coordinate annual nursing research conference, and I'm delighted to announce the next year our 5th annual conference, and everybody is invited. So come call in. So we produce internal nursing research bulletin, And we also present a research and quality bursary at the annual conference. So what resource we have so far? As I said, we are still babies, okay? We are still developing a lot of things. We are not the expert yet. So my job came in last year, same like Linda, before February 2013, the senior. Sorry. I know Linda very well, so excuse me. The purpose of the post to develop a hospital-wide audit and research strategy, to raise awareness of the audit and research process, to provide specialist audit, research advice and support staff. So just want to tell you, my job, point 5, is an audit, clinical audit. So I support all the discipline, not just nursing. I support NCST, I support department head, all psychology, social work, everyone. So that's point 5, my clinical audit. And point 5, research, I support nursing staff and I conduct international research. And my PhD is there, but that's where I work. So we have a plan to appoint a postdoctoral research fellow to work with the CNS and ANP. Why? Anybody know why? One of the core competencies, yes, one of the core competencies of ANP and CNS is audit and research. And these, we are hoping to get these fellows, so they will work very closely with the ANP and CNS to produce more research and publication. Because my job itself is hospital widespread, it's not just specific to one specific group. So these fellows will closely work with the staff nurses, CNS and ANPs. So this was a research activity snapshot from 2013. So you can see we have a number of ongoing projects, peer-reviewed publication, which is, I know is very low, but we are working on it. I cannot predict how much we expect, but people are working on it. So as soon as the fellows start working with us, we will be expecting more publications. And presentation at national and international conferences. We keep a record of all these things, just want to measure ourselves. And this is the 2012 snapshot. So these are the number of ongoing research projects 2013. Norma is here. Norma is one of our ANP candidate, and she is also a pain specialist. As a part of her master's, she undertook this research, the development of an algorithm for the management of pain in children post on appendectomy. Sorry, I'm keep translating. Sorry, Norma. So anybody want to hear more about Norma's study? Catch her. She's around here. And the next one is Tuna. She is a CNM2 working in the recovery. She conducted this research as a part of her master's. How effective is nurse-led airway management in the pediatric post-anesthetic unit? So she's not around, so you can't catch her today. And mother's experience of caring for a child with a gastrostomy at home. Etna presented earlier. Many of you heard Etna. If you didn't, she's around here. And then myself, I left a post outside. I didn't complete my study yet. When I started this study, I have to say I was a staff nurse. My interest came from the parents and the children. They are living with the reality of their child is going to die one day. So I want to explore their life experience and see how we can improve their service delivery. I knew that we cannot offer any curative treatment, but I just want to make sure we provide the best possible care for these families. So my post is out there. Anybody want to know more about my research, catch me. So here I just want to give an example of an nursing project. When we talk about the research audit, everything is very smooth. When you implement things, it can be difficult. My fellow colleague, Louise Greensmith, she undertook the research as a part of her master's. The time she was a staff nurse working in a general pediatric ward. What she identified was the nurses had a phobia of fever and they administered antipyretic in an effort to reduce temperature and prevent febrile convulsion. And we all helped. We all did that. We are still doing it. So what she really identified a gap between theory and practice managing febrile convulsion in children. So she undertook this research, aiming of describing nurses' knowledge and attitude towards fever and fever management. She approached all the nurses who work in industry, 119 respond back. So the finding from the study highlighted the nurses need to improve their knowledge of fever and to develop appropriate attitude towards management of fever. When you go back to her study, 74% nurses believe that sleeping children should be woken to receive antipyretic medication. Again, that finding was supported by other international studies. So not just herself, a lot of studies support the same kind of findings. Then what she did post-study, which is quite interesting. We all do the study, and sometimes those studies sit in the library forever. What will happen with those studies, which is quite important. So she updated pyrexia care plan based on 2007 and NICE guidelines. Antipyretic should not be used with the sole aim of treating fever, should be administered as an analgesic agent if a febrile child becomes uncomfortable. Is that okay? Everybody's okay? Then she updated all the discharge advice for the parents of children with febrile convulsion. She discussed her findings at the university level. She developed education intervention. What she did a focus group among staff nurses. She wanted to hear from the staff nurses how they can improve their knowledge. That is one of the best practice for the knowledge and attitudes. So she conducted this focus group. When you look at that result, the two interesting themes came out. The parents' pressure and the parents' pressure to treat their child when the child has temperature, and another one was medics. Medics want to treat their patients if they have temperature. If, as a nurse, when you work in the ward area, if you don't keep the calmer or improving, you will be asked what happened. So these research, the nursing research, was challenging medical practice. So at the moment, our second phase, Louise is looking at doctors' knowledge and attitude. So discussion at the high level, spoke to medical board, spoke to all the lead pediatrics. So they are in agreement. So we are looking into doctors' knowledge and attitude. Is that okay? Then we have monthly, we do have a patient safety and quality case series. So we present a number of cases and discuss. The interesting thing about the case series, we are very open. We talk, we discuss. Director of nursing, all the assistant directors, practice development, we all come together. We discuss, and there is an openness culture there. So nobody's afraid of questioning or asking. We need that because the culture itself is hard to change. So this kind of initiative is promoting quality and safety. And I would like to acknowledge the work of Kara Lukner and Sheila is organizing this case release. So we developed a nursing strategic plan. So from that, what SMART goal we are planning to achieve this year? We position ourselves as a nursing research in the organization. So nursing research, when you go to ethical committee or ethical approval, they don't really understand what nursing research is talking about. The number of patients, hermeneutics, phenomenology, grounded theory, they have no clue. So you want to make sure you position yourself in the organization as a nursing research. So we will be appointing a postdoctoral fellow, and we are identifying and supporting a lot of research activity and also looking for a funding. Sorry, I was asking funding, so that's the reason. So at the end, we are hoping to establish an institute of quality, safety, and team science. That's our mission. Oh, sorry, I didn't finish yet. Clinical audit, sorry, we finished 2 minutes. So I'm going to talk about clinical audit now. Clinical audit, the law of definition, okay, NICE best practice guidelines 2002, 68 words. I'm not going to talk about big long definition. What I want to say, you audit your current practice against the best practice, okay? And you have the vision of excellence, how you improve your practice. So when you prepare for audit, you have to think, what standard you're auditing against. If you have no standard, as I said, you can look into the current literature. You can draw a local standard with a local consensus. And make improvement, sustain improvement is very important. And create that culture. These are the current drivers of clinical audit at the moment in Irish healthcare system. ICWA, we have professional regulatory body like Nursing and Midwifery Council, Irish Medical Council, many more. This is the launch. So I really would like to thank St. Vincent's, Ian and Nora from St. Vincent's, and Mary and Colin from Surutanda. They supported me to establish this clinical audit in place in Temple Street. Our CEO and Director of Nursing, our clinical lead. So this is the structure in place. We have board of governors, board of directors. So we have clinical audit steering committee meet monthly. Approval group, steering committee meet every 3 weeks. Okay. So we have 15 members from across all the different departments, including Director of Nursing and Head of Pediatrics. We have an approval group meets every month to approve all the audits, because we want to make sure what our audit is happening, it should be good in quality, robust methodology, and implement in practice. So this is a process we have. I'm not going to detail of this process, so anybody want to come back another time, come back to me and I'll go through with you. What we have at the moment, we have policy, we have application form, we have report form, because once you finish your audit, I know some of them write report back to me, because what happened with your audit, what you identified, how you made changes, which is very important. I'll keep a record. Sometimes there is no general agreement among stakeholders. I have to escalate up to the management level, executive management level. And the clinical audit flow sheet, these are the things we have available in QuickBooks. So you select your topic, you identify stakeholders. What does that mean? Who will be doing audit with you? There will be a lead who is doing the audit. A supervisor supervises the process. Stakeholders who is involved with the audit. It can be anyone. You decide, you approve, then you keep going. Okay. Yeah. So these are the activities. You can see all the different disciplines. So this is a case study. I'm not going because we heard from this morning. So what I would like to conclude, with this message. We would like to support and promote conducting nursing research and clinical audit for building evidence-based research practice, nursing practice for improving patient safety and outcome, thus creating a culture center for excellence to care for children's health. That's it. And I would like to acknowledge Suzanne, Director of Nursing, Caroline, Practice Development, our Research Nursing Committee, and the Clinical Audit Committee. Thank you very much.
Very passionate presentation this afternoon. Our next presenter is Barbara Sweeney. Barbara works as a lecturer tutoring the education department in St. Francis Hospice. She also lectures on the Masters in Palliative Care, the Masters in Gerontology, and the Masters in Dementia in Trinity. So very busy lady. Barbara's previous work experience includes 16 years of clinical practice in palliative care in inpatient and daycare and community settings. Barbara has a higher diploma in general nursing, a specialist degree in palliative care, a postgraduate higher diploma in adult and community education, and a master's in education. Barbara is going to present for us this afternoon a presentation entitled Death Reviews, a stepping stone to reflective practice in end-of-life care. And the primary aim of the study was to gain an understanding of the benefits and challenges of two Irish interdisciplinary community palliative care teams' perspectives of attending a monthly death review meeting. The findings suggest that this type of meeting would be beneficial wherever healthcare professionals are looking after patients who die. Thank you very much.
Hi, I'm delighted to be here today, and thanks to the organisers for inviting me to discuss research that was undertaken in relation to a meeting called a Death Review meeting. I think this fits in really nicely with this morning and what was discussed by Professor Anne Scott in relation to humanising healthcare and creating a culture and a culture of care. Okay, so I'm going to start with the news flash. No matter what cohort of patients that you're looking after, you are going to encounter grief, loss, death and dying. And we only get one chance to get it right with those patients and their families. And we've discussed this morning how busy we all are, staffing levels, all that. So it's more important than ever that we get off the treadmill that we are on. We're lashing around the place. And we stop and think about how we cared for those people before they died, so we can learn from lessons and we don't make the same mistakes again and again, and we also can learn how am I in this so that I don't make the same mistakes again and again. Reflective practice goes back to the Greek philosopher Socrates, who said an unexamined life is not worth living, and I think that is both for personal and professional growth in relation to stopping and thinking about what we have done. And the meeting that I'm going to talk about is a cost-effective way. So we've talked about finance this morning as well, of education and learning, both personally and professionally. Okay, sorry. This slide was supposed to be black, and I don't know why it isn't. And what it was a pure black slide, and it was to signify darkness. And it was darkness in relation to our knowledge around death and dying. If I was to ask any of you, do you remember the first time you were with a patient who died? You all have that memory. You all know what it felt like. And it's something, as I'm teaching, I'm learning more and more, that people still feel that when you're not working with it, and sometimes when you are working with it all the time. It's, I don't want to say the wrong thing. I don't want to. You want to do everything to the best of your ability. And the darkness also signified darkness in relation to your own self-awareness. How is this affecting me? Because that does affect how you are with other patients and other families. And this was a chink of light. This was black and that was white. That the findings from this research showed that there was education and learning from meetings like this, and there's also an increase in self-awareness. And through attending these meetings again and again, that this got bigger and bigger. There's a lot of research about reflective practice, self-reflectiveness. It builds clinical competence and can prevent boundary violations and burnout. And Warden has written about regular staff meetings where participants are encouraged to talk about problems that arise in the care of the dying and their families and their own feelings, and how that can prevent excessive stress and can facilitate the feelings associated with grief and loss. I'm going to tell you a little bit about this elusive meeting that you may not have heard of. It's a local practice in 2 community palliative care teams in the Republic of Ireland. It involves the whole team, not just nursing staff, the interdisciplinary team, meeting once a month for an hour. It's very different from other meetings because a candle is lit. And I've never been at any other meeting that we're lighting candles in the middle of the room. So it's a very different feel to other meetings. What happens is there's a list of patients who have died. And this is transferable to wherever you're working. In this particular setting, there'd be, for any one team, there'd be up to 40 patients that would die a month. So a list of all those patients' names are read out, and there's a pause in between each name. And it allows people to reflect, and you might have looked after all the patients, but you would have heard the names within the team in discussions and meetings. It's then a free forum. The list is passed around so people can visually look at the names as well, and it's a free forum. It's whatever comes up for people. To discuss the patients that have died, their journey, care and death, and how it was for you as well as a healthcare professional. So there can be funny stories, there can be challenges, it's a free forum, it's whatever comes up, but there's that dedicated time for 1 hour once a month. My research question was, what are the perceived challenges or benefit of attending this type of interdisciplinary meeting? And why I was asking that question was, when I worked as a clinical nurse specialist, my own learned and lived experience, I had attended those meetings in the past. And I suppose I'd taken it for granted because 16 years working in palliative care, I got used to that way of working. And for me, we had never discussed as a group what this meeting meant to other people. We just attended it as part of our work. But for me, I knew that I had learned a lot in relation to culture, in relation to care, and in relation to boundaries, and in relation to all these things myself from attending the meeting. I felt supported as a result of these meetings, and I felt I had had personal and professional growth. There was an end-of-life care initiative in 2012 by Malloy and McQuillan, who looked at 3 nursing homes in the north side of Dublin. And what came out from that was that there was no formal process or structure like this type of meeting. There was masses that were held and different things like that, but there was nothing for the staff to look at the care that they have given and how they were in that. And also, I'm 3 years working in education now, and it became evident that whenever I'm teaching, I'm talking about this type of meeting, and I ask, what do you have? And there is nothing out there. And I just feel it's an area that we really need to look at for improving patient care. So the ultimate aim of Death Review meetings, in my experience, is to improve the experiences and care of dying patients and their families by enhancing the awareness and lived experience of the interdisciplinary team who work with the patients who die. The methodology I used was a qualitative research approach which explores the individual's lived experience. And specifically, I used an interpretive phenomenological approach, and that's concerned with a detailed examination of the human lived experience by bracketing or putting to one side the taken for granted world in order to concentrate on our perception of that world. We had never discussed these meetings, neither teams ever had. So for the data collection, there were semi-structured interviews. They lasted between 30 to 60 minutes, and they were audio recorded, and the full interviews were transcribed verbatim. I sent them back to the interviewees. What was interesting was I had to stop 2 of the interviews because participants became so emotional and needed time out. And I wanted to make sure everyone was happy with what they had said. As it turned out, no participant wanted me to change anything from the findings. There was 10 participants, including 1 pilot interview. All professions working in the team were represented. So there was 5 nurses, 2 chaplains, 2 social workers, and 1 doctor. We don't have healthcare assistants in the community as part of the palliative care team. There was 1 male and 9 female participants, and they were aged between 30 and 60 years of age. When analysing it, really, there was 3 themes. There was the process of the meeting, the self as carer, and the craft of caring. Looking at the first theme, the process of the meeting, exchange and detachment, relates to the exchanging of stories, of knowledge, and of experiences. And detachment was about people enabling closure, and that was a word that was used time and time again by acknowledging and naming, which was the next subcategory. And also detachment in relation to one of the participants had a very different coping mechanism, as everyone in this room would, in relation to grief and loss. And also the meeting being mandatory. And what was interesting about that was if you look at most of the literature around mandatory meetings, they're not supposed to be a good idea because you don't get buy-in, whereas 9 out of the 10 participants felt absolutely, when a patient dies, this should be part of the work in any area where people are working. So I'm going to go straight to the horse's mouth because I could talk for hours about this. So I'm going to give you some quotes from the first theme in relation to the different categories. On exchange and detachment, one participant said, if you had a very difficult situation, and again with either patients or relatives, sometimes it does help to talk about those situations. In a way, it is a way of unloading and being able to talk about how you felt, whether it was positive or negative. Another participant, in relation to detachment, said, I think I'm quite good at separating my work life and my home life. Like stress at work, I can honestly say, has never been an issue for me. And even despite being in some stressful situations or dealing with very difficult cases, I would very much look at it as my work. And when I go home, that's the end of my work. And that was quite unusual. The other 9 participants would have felt quite differently about it. So I just thought that was very interesting. In relation to acknowledging and naming, everybody in the naming of people out loud, everybody is remembered. I think at one level it allows recognition. It acknowledges the nature of the work. It gives people the opportunity to say goodbye or acknowledge the work that was done with different families and different family members. The other thing is to look at the way we journey with that person, the way we were with those people. Sometimes acknowledge our disappointments. So I think it's an opportunity where we can actually express our feelings around maybe what has happened with a particular person, and we can share with the other members of the team in a quiet, relaxed space. In relation to the meeting being mandatory, and I also asked about how would you feel if this meeting was stopped, and 9 out of the 10 participants got quite vocal about that, said you couldn't do that, that wouldn't be right, and I thought that was interesting as well. I think it should be mandatory. I think the time should be set aside. The benefit for us and for the patients. I'd have to ask why in relation to stopping this meeting. I think I would probably be looking further if it was removed. What will we do with all those people who have died? You know, where do we put them? In relation to the second theme, self as carer, and exposed to the reality of death and dying, I'm very sad at times. I get very close to people. You know what's going to happen, and it's kind of what takes over is hopefully it will be okay. So that kind of takes over from the actual loss end of it. Because you want it to be a peaceful end and you want the family to cope with it. And you want them to be prepared. So it's kind of like if the preparation work is done, And if you feel they're going to cope well, then I cope. And that was really how they looked on the reality of doing that. How much death have we actually gone through this year? Never mind personally, professionally, how much life and death. And sometimes you kind of take it for granted and you just kind of plod along. And for me, death reviews, they kind of pull it in. Every now and then you kind of go, God, yeah, how are these families doing? These people are not just numbers, they're actual people. In relation to reflecting on practice, so it will give you a chance to reflect on what happened and then bring up and discuss a patient, what happened, you know, their symptom control issues, or how it worked out, how we managed it, you know, whether it went well or not. For the team, it's good. Improve on that. So constantly looking at what we did and how can we improve on it in the future. I think it's an enriching experience. This is in relation to the death review meeting. It's a special time of transition, and we should always mark it as being that, as learning from it, because that is how we go forward. By looking behind and by seeing how our experiences have affected us in a way that's going to influence how we are going to be in the future. Well, that's major. In relation to the third theme and the craft of caring, teamwork came up. You get the experience of the other staff. You get the experience that you haven't had, and this would have been in the past where I would have really learnt from listening to the more experienced staff when I first started attending these meetings. Well, I think it brings the team together a little bit and reinforces trust to be able to speak. And this was really interesting because I hadn't thought about this before I did the research. This was really seen by most of the participants as a team bonding exercise because it was so different to other meetings. But what really came across was what was important was you had to feel safe in that space. So the idea of having ground rules was brought up by a number of participants, that you felt safe to speak or felt safe to say, I was challenged by that. I think maybe one of the challenges would be if there was a member of the staff in the room that didn't really take the meeting seriously or didn't participate in it. You would tend to hold back if you feel that somebody else hadn't taken part in it. In relation to learning and developing knowledge, the main thing is that you do reflect on, you know, a clinical level, management-wise, managing symptoms, and sometimes changing your practice. And you try to learn from basically what went right and what went wrong. The other element of it would be learn from some of those reflections. Because what we're doing is we are reflecting on how things have been for us in the caring. In relation to relationship or skill companionship with patients, we are doing the job we have gone there to do, but a relationship is being built, you know? And sometimes people will talk about maybe the laughs they had with the person, maybe the times that things were upset. So there's a lot of that, acknowledging the goodness in the person and acknowledging the human side of the normal person. And if you look at mid-Staffordshire, that was one of the findings that came out, that people had dehumanized themselves from patients. So meetings like this are really important. We look at the way we journey with that person, the way we were with those people, with the person and with the family. Because in a way, you're sharing a bit about yourself as well, because relationship is reciprocal. Significance of the study. 10 out of 10 participants saw the value of having death review meeting. That one participant that I spoke about, whose coping mechanism was very much involved, attachment, saw the value for others but didn't see the value for themselves. I was really glad that participant came forward because their views were very different from the others. And I think within a team, within any team, you're going to have people with different coping mechanisms, and we need to try and be able to understand each other, why maybe someone's more emotional or why maybe someone seems more detached. That it is just down to coping mechanisms, how we all are. 9 out of 10 participants felt that this meeting should be mandatory for all healthcare professionals, not just professionals working in palliative care. And that one participant didn't mind either way, didn't have strong feelings. The only challenges that were reported was the timing of the meeting. Afternoons were seen as better because patients had been visited, and also if the participants didn't feel safe to discuss their feelings within the group, that was seen as a challenge. Factors I hadn't considered: the importance of ground rules, trust and respect. It won't work if you don't have that. So you need to set rules as a group before this type of meeting. This meeting was seen as a team bonding exercise. The use of symbolism, I hadn't thought about that. And what was interesting was, I knew the candle was there and I liked it, and I knew how I felt when I had attended those meetings. When the candle was blown out, I always felt a sense of closure, because we had talked about the patients, we'd acknowledged them in their life and their care. But the candle meant different things to different people. One of the participants said that when they lit the candle, it brought all those patients, all the names to the table. Another person said that when they lit the candle, that there was a feeling of trust in the room. So it just meant different things to different people. And then how differing coping mechanisms affected how this meeting was viewed. We've talked about the Francis report, we've got a few people talking about big stature. I think it's really important that we learn lessons from this, and I really like this from Robert Francis. He said, people must always come before numbers. Individual patients and their treatment are what really matters. Statistics, benchmarks, and action plans are tools, not ends in themselves. They should not come before patients and their experiences. That is what must be remembered by all those who design and implement policy for the NHS, and that's directly transferable to the HSE. I'd like to take this opportunity to thank the Research Ethics Committee, hospice and community palliative care teams, as well as all the patients I've cared for over the years who inspired me to undertake this study. And I'm delighted to say that I've secured funding from the NMPDU to roll this out in areas of intellectual disability. So I'm delighted to be starting that in October. So thanks very much.
Indeed, Barbara. I think that presentation provided us with a very valuable and reflective time in terms of the structure that's operating within palliative care. I think there's probably a lot of transferable learning for other services, maybe where that's not happening, but would be equally valuable. So thank you for that. Our next speaker is Ken Levy. Ken has just completed his Master's in Nursing and is working towards the Advanced Nurse Practitioner in Emergency Cardiology. And his student code has been approved. Ken completed a Bachelor in Nursing Studies, a postgraduate diploma in Accident Emergency Nursing, and is also a registered registered nurse prescriber. Ken's most recent research presentation was at the European Society of Cardiology in Glasgow. Other areas of interest include interventional cardiology, arrhythmia, out-of-hospital cardiac arrest, and chest pain. Ken has presented at both national and international levels of the above-mentioned topics. The presentation this afternoon is entitled A Prospective Observational Study of Atrial Fibrillation Treated with Early Cardioversion delivered by a clinical nurse specialist and senior physician in an emergency department in Dublin. So, Ken, thank you very much.
Thanks very much. Good afternoon. Special thanks to Etna and Linda for their help and support in getting me to this place, I guess. My heading is quite a mouthful, but hopefully I'll get your head around and that you can get a good understanding of what is atrial fibrillation and the impact it has on patients. And this is our Conwy Hospital Emergency Department, and that's where we're at. I thought this was very important. Albert Einstein said that if you can't explain it simply, then you don't understand it well. So I hope by the end of this presentation, you'll all have a good understanding of treatment modalities and definitely the signs and symptoms associated with this arrhythmia. So the background of the study. Atrial fibrillation is the most common arrhythmia that we see in emergency departments, and it's increasing in prevalence and it's increasing with age. People are living longer, and you just have to walk through an emergency department to see the elderly population. I suppose atrial fibrillation traditionally in Ireland were managed by cardiologists, where most patients would require very much rate control of these blockers and indeed anticoagulation, which was working. Early cardioversion for acute atrial fibrillation increases the likelihood of patients remaining in sinus rhythm. Because in atrial fibrillation, the atria get slightly enlarged. It's called a tachycardia-induced myopathy. Myo is muscle and opathy is enlargement. And when that happens, it's less likely that the patient will remain in sinus rhythm. So our goal is to get this treatment in as quick as possible, and the goal of that then is that they will remain in sinus rhythm. I suppose our department is no different than the national departments in Ireland. There's growing pressure on beds. In most cases, patients are lucky to get a chair, let alone a bed. And I suppose we have to prove our worth, and we have to prove that by doing this, it has a significant reduction in cost. So if we look at the epidemiology of atrial fibrillation, it definitely increases with age, and approximately doubles with each decade of life. About 9% of the adult population over 80 will develop atrial fibrillation. It's estimated to be at 1 to 4%. Women are less likely to develop AFib than men. That's something in the study that was very. It's uncommon in children unless after congenital cardiac surgery. It's associated with significant morbidity. And when I talk about morbidity, I'm talking about embolic strokes. Also has a significant reduction in the patient's exercise tolerance. And as I mentioned, tachycardia-induced myopathy. The annual risk of stroke in patients is estimated to be 5%. Patients that don't have AF are 2 to 7 times less likely to develop stroke. So we look at the etiology of atrial fibrillation, and there are cardiac and there are non-cardiac. I suppose I always ask the question, why? Why has this patient gone into atrial fibrillation? And sometimes we find the cause, and sometimes we don't find the cause. And sometimes there's no reasons for this. We just haven't found out. But we've excluded a lot of things in our process. In relation to ischemic heart disease, that's patients that present with acute coronary syndrome. 20% of those patients are likely to develop AFib. Valvular disease, as in aortic stenosis or mitral valve problems, hypertension, hypertensive heart disease, which is left untreated, and congestive cardiac failure are three of the most common symptoms that are presented in emergency department. DCM stands for dilated cardiomyopathy. Cardio is heart, myopathy is muscle. When you get dilated the cardiac muscle, they're more likely to develop atrial fibrillation. Cardiac surgery, as in post-bypass, valvuloplasty, etc., may also develop. And perimyocarditis, which is something that we see quite regularly in the young population. Peri is the outside of the heart, pericarditis, myo is the middle, and endo is on the inside. So when you get inflammation of the perimyocarditis, you get a troponin leak, and that leads to irritability of the heart, and they're more likely to develop atrial fibrillation. When we look at the non-cardiac cause, pulmonary disease, as in emphysema, COPD, you get increased right atrial pressure. Holiday heart syndrome, I was patient yesterday with holiday heart syndrome. It's quite a colourful term, but why does it happen? It happens with excess alcohol use. And my patient yesterday was away on holidays, drinking 7 to 8 pints with a couple of whiskies in Spain, developed atrial fibrillation. We were able to put him to sleep, resynchronize his heart, and get him back into a normal sinus rhythm. And that was done as quick as possible. Thyroid disease, and I'm talking about hyperthyroidism. In a study by Langston et al., he found that 35% of his sample, which was a small sample of 50 patients, 35% had undiagnosed hyperthyroidism. Medication non-compliance. In the elderly population, medication non-compliance is the single most common presentation of patients that present with really fast, irregular heartbeat. Pulmonary embolism occurs as a result of increased right atrial pressure. And medication non-compliance, I also meant to mention about cocaine and theophylline overdose. During the Celtic Tiger, we saw quite a volume of patients, young people, presenting with chest pain, atrial fibrillation as a result of cocaine. Not as much now because I can't afford it. And theophylline. It's just these are things that I bear in mind when I go to see a patient, and I work these out in my head. The electrolyte abnormalities, and I'm talking about hyperkalemia, which is low potassium, or hypomagnesemia, low magnesium. So you would check those in the patient. Hypothermia, you're talking about temperatures less than 32 degrees. And there is a risk that the patient 32 degrees, less than 32 degrees, may develop atrial fibrillation. There's also a risk that a person that's hypothermia, if you warm them too quickly, there is a risk that you can develop atrial fibrillation. So it's 1 degree an hour you raise the temperature, so you have to be quite careful with that. So I thought this slide is important because I want to get this across that people understand. And a lot of people get a block in relation to rhythms. And they really aren't that difficult to explain right. So hopefully it's explained. So if we look at the activation in normal sinus rhythm and during atrial fibrillation, and you can see at the top slide here, the reason that's normal sinus rhythm is because impulses are coming from the SA node. This is the SA node, that's good. yellow dot there, they send impulses to the AV node, which acts as a kind of a filtering system. And that's enough to stimulate the Purkinje fibers down into the left and right bundle down to the Purkinje fibers, and the whole cardiac cycle begins. And you can see at the top rhythm that you have a P wave, you have a QRS complex, QRS, and you have a T wave, and you can see it's quite regular, and the rate is 60 beats per minute. In atrial fibrillation, you get activation of whole wave shape, and then yellow dots there, they're called foci, and then foci confuse the SA node. So impulses don't come from the SA node, they come from other areas within the AV shape. And unfortunately, the AV node, as I said, acts as a filtering system, cannot allow all those impulses to be processed. It's like going to a traffic lights at the junction and the lights are green. Everyone can't go at the same time. This irregular pattern. So the characteristics of atrial fibrillation are, number one, impulses do not come from a P wave. So you're not going to have a P wave. The P wave you see here, you can't identify a P wave for every QRS complex. And number two is the rhythm is going to be chaotic and irregular. And you can see, if you measure these R waves out, you can see they're quite irregular. So that's the characteristics of sinus rhythm and the characteristics of atrial fibrillation. The ED evaluation is very important. And I suppose the most important thing is to recognize that it is this. Because then you can put the treatments in as they are. To recognize if a patient is stable or unstable. And what you do in relation to an unstable patient. We all know the oxygen IV access monitor, etc., etc. You stabilize them. You do various diagnostic testing. When I talk about diagnostic testing, I'm talking about an ECG, which is the gold standard. And we do specific types of blood tests. We check the full blood count. We check the white cell count for infection. We look at the platelets. Could it be thrombocytopenia? Is it an infection? We have a look at the coagulation studies. We have a look at the renal function, their liver function. We check their thyroid. Could it be hyperthyroid? We look at their inflammatory markers. And we also look at their troponin. Cardiac troponin is a specific tissue, and it's a specific blood test that's done for tissue damage as a result of, say, myocardial infarct. As I mentioned earlier, it happens in about 20% of cases. And then I start the head-to-toe assessment. And the history is where you get the clues. So the first thing, when you examine a patient, you'll feel his pulse is irregular. And then you look at the ECG and you say, this is atrial fibrillation. You do a neurological exam, you examine their neck. Don't forget about their neck, because if you get increased JVP, it can be a sign of increased right atrial pressure. And you might think, has this patient developed cardiac failure? You also look at the thyroid nodule. And sometimes you can get fullness in the thyroid nodule, or you can get a goiter. And you think it would trigger you to test. Okay, let's check this guy's TFTs, and especially the TSH. And then you work your way down to the cardiovascular examination, and you make sure the patient doesn't have a murmur. Because if you have a murmur, it means that there's turbulent flow through a valve, so you have some sort of a valvular problem. And in those cases, we get a transthoracic echo. So we put some gel in the probe and have a look to see if there's a leaking valve. We also have a look to see that there's no evidence of pleural effusion and the deltoid function is normal. And then you examine the lungs and you work your way down as you do. History taking is very important because you get a lot about the history. And the group of patients we looked at, they have to be specific about their onset of symptoms. So when I say they're specific, it has to be less than 48 hours. The physical examination is vital, and review the ECG, as I mentioned. What are the benefits of maintaining a patient in a normal heart rhythm? They have better quality of life. I've seen patients come in the 50s, 60s, or 70s that walk every day, swim every day, and you review them again. They're not able to walk, they're not able to continue the activities of daily living. And that can have such an impact on their quality of life, and it does get them quite down. So it's great to be able to talk to them, to correct it, and improve those symptoms, because they are quite appreciated. The goal is to lower the risk of patient developing an embolic stroke. A stroke can be devastating for patients. Their symptoms improve and their exercise tolerance greatly increases. And there's also this risk of anticoagulation. Anticoagulation is all well and fine as long as you don't develop a bleed. You're not involved in an RTA or something like that might make you worse. Higher risk of bleeding, because that can be detrimental, and also to improve the patient's survival. In assessing these patients, we use a scoring system called CHA-DRAS-2. And this is a scoring system to determine who's at risk of developing a stroke. So when you're examining the patient, you look for signs of congestive cardiac failure. If there's none, it's 0. What's their blood pressure like? Are they on antihypertensives? What's their age? Have they got diabetes? Are they on diabetic medications? Have they had a previous stroke or a transischemic attack in the past? Is there any evidence of vascular disease, as in an aneurysm, etc., etc.? You look at their age and you look at their sex, male or female. And the slide on the right shows the risks. It shows the percentage rate per year of developing a stroke. And I always use that in every patient. And in my notes, I will always write the risk of CHA2DS2 score is 0. This is a low risk of score 1.3%. Okay? Because that will determine whether you put this patient in anticoagulation after you do the procedure or whether you just leave them be. So this is a prospective observational study. It's a convenient sample of patients presenting to a Dublin-based ED, and specialist nurses available. Adults presenting with symptomatic acute AF less than 48 hours. It was conducted over a 14-month period. DCB is electrical cardioversion as a primary method compared to pharmacological. So if electrical cardioversion wasn't suitable, pharmacological cardioversion or patient preference, it all depends. We have very strict inclusion and exclusion criteria, because the last thing we want to do is put a patient to sleep, recorrect their heart rate, and have a stroke. That's the worst case scenario. So the patients in this study had to give a very clear presentation of when their symptoms start. And most patients will, if it's less than 48 hours, they're included for electrical therapy. If it's outside of 48 hours, they're not, because they're high risk of developing a stroke. So that's very important. And that has to be the golden rule. Patients have to be fasting for greater than 6 hours. If the history is not clear, then you don't attempt to do a direct current cardioversion. And you exclude high-risk patients, those that are hypertensive, diabetics, previous TIA, etc., etc. And then unstable patients, we treat them as per ACLS guidelines. So the primary outcome of this study was to assess the effectiveness of this method of cardioversion. The secondary outcomes was to have a look at the length of stay. Does it have an impact on the length of time patients spend in the hospitals? To record any adverse events associated with this cardioversion, and also to have a look at, well, what's the recurrence rate of arrhythmia? It's predominantly male, as I mentioned, 23 were male, 6 were female. The average mean age was 56.7. Mode of arrival was ambulance 8, GP referral 11, self-referral 10. Patients were quite good in relation to the presentation of symptoms, mean 7.7 hours before they arrived, with a heart rate of arrival of 160. The symptoms varied. The highest was dizziness, palpitations, some chest pain, etc., etc. In these group of patients for electrical cardioversion, airway was managed by the emergency medicine registrar or the consultant, anaesthetics, or cardiologists. The pad position was anterior-posterior, so when I say anterior, it's just below the clavicle, one pad here, and posterior, it's just below the left scapula and the back. And that's the position you use. It's supposed to yield, it does yield greater results. And that was done with 28 patients, and anterior was 1 other patient. The energy used was 150 joules for 23 patients and 200 joules for 6. The number of shocks, 25 patients had 1 shock, 1 patient had 2 shocks, and 3 had more than 2. 24 out of the 28 patients responded effectively to cardioversion and resulted to a normal sinus rhythm. There was 1 pharmacological intervention, and that was 100% success, but it was only 1 sample. There was no adverse events reported related to cardioversion. And some of the adverse effects that can happen as a result of sedation will be your patient stops breathing, and a lot of the time you just open up the airway, you increase the oxygen flow. It's just all about, I always find that when you're doing these things, if you're prepared for every outcome that you work out in your head, then you're controlled. And in a situation like this, if you have these things worked out in your head, if the patient gets propofol and his blood pressure drops, you have IV fluids hanging. You're not running around trying to you prepare for all the inevitabilities. There was no thromboembolic events reported at cardiology follow-up at these stages. Now, the studies that looked at the risk of thromboembolic events, that's you speak to any cardiologist, and they're not really, the jury's out on whether they're happy with emergency departments doing these cardioversions. But the research papers that have been done on this have demonstrated that cardioversions for patients that present less than 48 hours is safe and it's effective. That's the most important thing. Is it safe and is it effective? And yes, it does demonstrate that. It demonstrates it up to 6 months. No studies have gone beyond a year. But 6 months for me, I'd be happy enough for that. So we looked at length of stay. And if we looked at the 2011 figures, there was 146 patients with an average length of stay of 5.6 days. So in 2011, a patient presents to Connolly Hospital Emergency Department, they're admitted for 5.6 days. For the cohort of patients in this study, the average length of stay was 7.7 hours. And indeed, we've probably got that down to 3 or 4 hours, because a lot of the literature says it's a bit of overkill. We want to make sure. But a lot of the research says that it's 2 to 3 hours and they're safe enough to go home. What is demonstrated in total 162 hospital bed days were saved. That's quite a lot of money. In our hospital, a monitor bed costs between 6 and 740 euros per day. So if you multiply 162 by 540, you get over 100,000. That's a significant reduction for such a small group of patients. So, 25 of the 29 patients were treated successfully with DCCB, direct current cardioversion. And I never explained what that is. So when a patient comes in, they're in atrial fibrillation. It's less than 48 hours. Anesthetics, A&E registrar, or consultant will sedate the patient. We will put the pads on, we'll press the synchronize button on the defibrillator, because that sends it on the R wave. If you fail to do that, you're likely to send the patient into ventricular fibrillation or ventricular tachycardia. And they're two of the most lethal rhythms. So you don't want to do that. So you press the sync button, and it will send on the R wave. Then once the patient is sedated and given some opiate, as in fentanyl, we deliver shock. Atrial fibrillation tends to be higher joules, 150 joules, and you shock the patient. In 86% of our patients, we maintained a sinus rhythm of this. And that's consistent with international practice. 5 patients returned within 6 weeks to DD, recurrence of the same arrhythmia, slightly higher than what the literature says. It says about 10%, we're 17%. It does have a significant reduction in the median hospital length of stay, and that's demonstrated from 5.6 to 7.7 hours. And as I said, I think it's much better now. Because as the service becomes more and more established, you'll find that you do tweak it a little bit better. And it does become, it becomes, I suppose, what's the word I'm looking for? I don't know, it's not there. Efficient. Thank you. We're able to develop a protocol, and I can't take any praise for this, because this was developed by one of the cardiologists in our hospital, Dr. Joe Galvin, and he's very pro nursing services, and he's very pro extending and expanding roles, and that makes my job a lot easier. And because if you don't have support from your colleagues, this wouldn't be happening. So just to go through this very simply, it's less than 48 hours. You can go mechanically or you can go chemically. You can go chemically with drugs or you can go mechanically, as I've said. But the problem with chemical drugs is this huge cost. There's certain types of drugs, like take vernicalin, for example. It's a very good antiarrhythmic, but it's 700 euros for the drug. An ampule of midazolam is probably a couple of euros, and you have the services. You have the services in your department. So to me, it's a no-brainer. And then you can give them the antiarrhythmic drug, and it mightn't work, and you end up putting them to sleep anyway. So it's a nice protocol, and what the protocol does is it ensures consistency in the treatment. So you don't want a service that works when you're there. You want a service that works 24/7, because it's for the patients. And as I mentioned, the quicker you get these patients back into normal sinus rhythm, the more likely they're going to stay in it. And if it's delayed, it's probably, the incidence of reoccurrence is probably over 40 or 50%. And these patients just find, oh, here, I met you before, and I met you before that, and I met you before that. And then they go on the list for what's called electrophysiology studies. We try and do pulmonary vein isolation, we try and ablate the pulmonary vein to stop the incidence of atrial fibrillation occurring. So, to conclude, ERIE, direct current cardioversion led by a clinical nurse specialist and in emergency cardiology, is a safe and effective management strategy for patients that do present less than 48 hours. Patients that present with ED with recent onset have a reduced length of hospital stay, and I've demonstrated that. The protocol was implemented in the ED following completion of the study because it ensures consistency. A nursing pack was also introduced, which included an integrated care pathway for patients that present. It includes an information leaflet about the condition, and it includes the consent. And it also includes discharge advice in relation to post-sedation. Now, I have to be honest, I've just finished my master's, the pathway isn't finished yet. That's something, it's a work in progress, but it will be done hopefully over the next couple of weeks. And that's very important. It's very important from a nursing background. We've had no reported episodes of thromboembolic events, and then that would be consistent with international literature. Thank you very much.
Thank you very much indeed, Ken, for that very detailed presentation. I'm sure we all wish Ken well in his continuing studies towards AMP status. Our next presentation will be made by Imelda Noon, and Imelda is presenting this afternoon on behalf of herself and Gertie Coyle. Is Gertie just here? How are you? The study this afternoon is entitled The Enhancement and Further Development of the Therapeutic Environment in Psychiatric Intensive Care Units through Psychosocial Interventions. Imelda is Nurse Practice Development Coordinator with responsibility for 2 approved centres and community services in the Dublin North City Mental Health Service. In partnership with DCU, she's responsible for overseeing the clinical component of the BSc in Mental Health Nursing. She is an RPN and RGN and has spent many years in nurse education as a nurse tutor and now as NPDC. Imelda also has a Master's in Education and plans to commence a Master's in Personal and Executive Coaching in the autumn. Gertie, sitting here in the front row, obviously drew the long straw. Has recently been appointed an Assistant Director of Nursing with the Dublin North City Mental Health Service. As an Assistant Director of Nursing, she's now responsible for the delivery of an efficient mental health nursing service within the hospital and community. She's an RPN, RGN and BNS and has spent many years in nurse education as a clinical placement coordinator.
Thank you very much. Thanks, Anne-Marie, and again thanks to Ethna and Linda for all her work and help and support in getting this action research project ready to present today. And as Anne-Marie said, the title is The Enhancement and Further Development of the Therapeutic Environment in Psychiatric Intensive Care Units through Psychosocial Interventions. And for those of you who may not be familiar with some of the definitions, I'll be given definitions throughout the presentation, and please excuse me, the ones that do know all these definitions and will be hearing them, will be very familiar with them. But just starting off, what are our psychiatric intensive care units, or PICUs? They provide psychiatric intensive care for patients who are in the acutely disturbed phase of a serious mental disorder and are compulsorily detained in the state environment. There is an associated loss of capacity for self-control with a corresponding increase in risk which does not enable their safe and therapeutic management and treatment in the general open acute ward. And that's from the Department of Health 2002. And just from the point of view of our PICU units in Dublin North City, we would accept transfers from all of the Dublin region, Dublin and Wicklow regions, for patients who cannot be managed in an open acute ward and who would be exhibiting, say, challenging violence and aggressive type behaviour. Just setting the scene and just where we've come from and where we're going. A lot of people would know that the original PICU units, which some of our research would have started in these original PICU units, were in the large old institution of St. Brendan's Hospital, which gladly closed its doors a year ago. And we all would be, certainly would say it should have closed 20, 30 years ago, but times didn't lend itself to that. We've now moved to purpose-built units on the North Circular Road, Phoenix Care Centre. I believe it cost, not bragging or anything, but I think it cost in the region of about 30 million. And like what Suja was saying, you know, you're all welcome to come and look at it. It's an absolutely fabulous place, just don't all arrive at the time. But we would love to show people around. We're very proud of it. And apart from being proud of it, we're just so happy that our patients, after all these years, you know, living in those terrible environments, and that terrible environment now have this wonderful facility. And it's beautiful, and we're delighted with it. So the majority of our projects actually, it started in the PICU units in St. Brendan's Hospital, and it's then moved to the Phoenix Care Centre on the North Circle Road. The IT is a bit skewed, is it? But our action research project is based in two particular units. One is a 12-bedded PICU unit in Phoenix Care, and the other is a 12-bedded female PICU. Just in relation to psychosocial interventions, what are we talking about when we're talking about improving practice and changing culture? We're talking about a range of activities that are designed to enhance an individual's social and psychological functioning. The intervention is focused primarily on working with people with psychosis, their families and caregivers through developing social skills, interpersonal relationships and communication. It's underpinned by a stress vulnerability model and a vision for recovery. And we do know that the modern mental health nurse has changed. Mental health nursing has evolved and changed so much over the last number of years. And it's changed from that traditional kind of caring, observation, close observation, kind of monitoring type of mental health nursing, now to a more recovery-focused, collaborative approach to care, which we are, again, supporting and promoting. When we're talking about psychosocial interventions, more specifically, we're talking about the whole engagement process and management of the therapeutic relationship. And again, we hear a lot of people talking about the therapeutic relationship, but it's talking about those key interventions that mental health nurses do to try and develop, and get them over out of the relationship with the person. Working with families, doing a biopsychosocial comprehensive assessment, elements of cognitive behavioural therapy, psychoeducation and relapse prevention, hugely important as well, and teaching our patients to be able to manage their stress levels, look at problem-solving, solution-focused approaches, and coping with different problems and issues that come up from a mental health point of view. Medication, adherence strategies, and motivational interviewing. So when we're talking about psychosocial interventions, that's generally the areas that we're talking about. And they're certainly all evidence-based approaches that we're trying to promote, that there would be routine practice in our mental health PICU units. Just from everybody has a different meaning or a different interpretation of what recovery means. And I suppose one of the most common ones that are used is one by Anthony in 1993, which is, he says, it's a deeply personal, unique process of changing one's attitudes, values, feelings, goals, skills and roles. It is a way of living a satisfying, hopeful and contributing life, even with limitations caused by illness. Recovery involves the development of new meaning and purpose in one's life, which is very, very it certainly captures what we're all talking about when we're talking about recovery and recovering from mental illness. Recovery focus is driven by certainly many documents since 2006. Vision for Psychiatric Change was probably one of the first ones that mentioned recovery, and certainly all of the documents from the Mental Health Commission and ETHNA's Vision for Psychiatric Nursing, and the most latest one, which is Mental Health Reform, again looking at what should a recovery-focused service have, to be recovery-focused. We don't have them up on the slides because, like the IT system, sometimes our scanners weren't working when we were sending them a presentation. So the aim of our study was to investigate nurses' use of psychosocial interventions in clinical practice pre and post a 5-day PSI training program, and the perceived benefits to service users. Our objectives were to explore the variety of nursing interventions carried out pre and post a 5-day training program. We wanted to look at developing and enhancing nurses' skills, attitudes, working in the PICU units. And we wanted to have more leadership and a commitment to a culture that supports innovation, creativity, and certainly elements of recovery. And we wanted to have a new and shared vision of what the nursing care that would be offered in our PICU units. Our design and methodology was an action research approach. We had mixed methods. We have focus groups looking at exploring nurses' interventions prior to, say, for example, initiating seclusion, which I will give a definition for in a minute. We reviewed all our records of seclusion and looked at statistics and what was happening in relation to seclusion. We looked at patient satisfaction surveys, and then finally we looked at a thematic analysis of nursing documentation and care planning process. And at this stage, I'd just like to point out that it's action research which continues and ongoing. We've heard loads of people talking, including Linda, talking about action research today. Up until now, we're at the stages of we've done pre-training the focus groups, the review of the seclusion records and patient satisfaction records. We've managed to do the pre-training data collection and analysis, and we've done pre and post data collection and analysis in relation to the documentation and looking at what was happening in the nursing documentation. The action research cycle, it's already identified by work by Kurt Lewin, and we just found it very, very helpful in relation to guiding and generating ideas and reflection in relation to where we are with the action research and where we need to go. So we just look at it from the point of view of what we did and where we're at. The planning stage, we did a training detailed training needs analysis in 2011. We knew we were moving from the old institution again, and we were looking at what staff again wanted to look at. What do they want to bring to the new unit? What kind of changes and what kind of development and what kind of professional development needs did they need? To come in and have new creative ideas in the new Phoenix Care Centre. So we knew we were moving. Staff themselves were looking for changes in practice and new developments. We had a lot of meetings and we had continuous meetings with our staff, but we met with our higher institute colleagues, looking at ideas. What were we going to put into a training programme? What were we going to include and what were we going to exclude? It was going to be a 5-day training programme, and looked at the kind of the bones, or the initial bones of planning the training ideas. We set our aims and objectives for the action research, and off we went. And again, stage 1, the acting, we got our ethical approval, we got funding from ETNA and the NPTU, and we started collecting our quantitative and qualitative data analysis in 2012. The final programme was identified in association, or in collaboration and association with our colleagues in the University of Nottingham, Dublin City University, and the Centre for Nurse Education and Economy. We got Nursing and Midwifery Board of Ireland Category 1 approval, and we ran the 5-day programme was delivered. The first of them was delivered in 2012 and then on to 2013. 43 staff participated in the programme over 3 particular days, and while there was no particular assessment on the programme, there was pre and post training questionnaires. Just moving on again, the cycle, stage 1, the observing. We started to collect our post-training data collection. We started that in 2014. We did do a lot of reflection, again keeping with the cycle. We stopped and thought about what do we need, where do we need to go, what are we going to do from here. Any of you that would have seen Anthony Coughlin's poster out there at break time, it was the introduction of a staff observation assessment record, which again gave us more data and more information about what actually nurses are doing. People don't just initially put someone into seclusion, and they're really define that in a minute from my audience who don't have the background in it. But it was looking at what nurses are doing, what kind of interventions that they're doing before they actually have to initiate seclusion. We set up a support group. Again, all the literature would look at, you have to support a change in practice, and you have to support, if you're trying to promote new cultures and practices, the support and guidance has to be there. Clinical supervision. Well, we always had pockets of clinical supervision, like our clinical nurse specialists had supervision, some of our community mental health nurses, or probably all of them, had availed of clinical supervision. But we didn't have anything structured from a clinical supervision point of view in the Dublin North City. But we now have 11 people qualified in providing clinical supervision skills. It's available now for everybody. So every member of staff can avail of either one-to-one clinical supervision or group clinical supervision. So that was an initiative that it certainly support and help to embed psychosocial interventions. And we certainly be continuing with our post-data collection. Sorry, repeating myself there. Another interesting thing, when we look at the revised plan and continuing on our action research cycle, that we now, in collaboration with our colleagues in the Centre for Nurse Education, they now have a level 8 certificate in psychosocial interventions, and 3 of our staff are actually completing that at the moment, which again will help to embed the whole psychosocial intervention from a practical point of view in practice. A journal club. We have a very successful nursing journal club in the community. We're trying to transfer it and have one in the Phoenix Care Centre where people can come and talk about their work they're doing from a recovery point of view, or different psychosocial interventions that they're working on a daily basis. Seclusion, just before I go on to talk about the records of seclusion, is the placing or leaving of a person in any room alone at any time, day or night, with the exit door locked or fastened, or held in such a way as to prevent the person from leaving, and that's the Mental Health Commission 2009. And just getting on to our research results, our action research results. This was our focus groups that we did on the interventions used by nurses prior to the initiation of seclusion. 18 staff participated. There were 4 different groups. We had 7 preset questions. And we used qualitative thematic analysis by Braun and Clark. And the themes that came out were the time frame. And just quotes from nurses, it certainly is a last resort. As I said, people do not place anybody in seclusion unless there's absolutely no other alternative available to them. We try everything to create a safe environment. The alternatives that were identified that nurses would use: talk down, distraction, giving someone space, using the garden, and look at one particular resident, they were looking forward to the move to the new unit with loads of space and a nicer environment. And as you can see from the pictures prior to this, there certainly is plenty of that. Personal feelings, relief. You do feel bad, it does affect you, but you have no alternative. It's not nice taking somebody's liberty, but you do feel safer. And then training and education was the other thing that was identified, and people, or the staff in the focus groups identified that they needed more approaches to care. They needed more examples in relation to their communication skills and their de-escalation techniques. And again, as I say, we have to go back now and do post-data collection in relation to our focus groups. If we just look at our seclusion, our records on seclusion, and even though 2010 wasn't in the initial, it's not included in the action research, commencement of the action research project, we just put them up from the point of view that it's heartening. We're absolutely delighted that if you look at the statistics for seclusion orders in 2010, that there were nearly 250 orders of seclusion. That is drastically down, as we can see, for 2011, 2012, 2013, that the numbers are down drastically, which is, obviously now that we've moved to the new unit, the environment will have an impact. But certainly the experience of staff and the dedication and commitment of staff to trying different approaches. They may not have known exactly that there were all psychosocial interventions, but people try a variety of different approaches, and it has helped in the reduction of seclusion, of the seclusion orders. And I suppose the other thing to go back to is that our seclusion orders sometimes can be high because we are the PICU unit for the whole of the Dublin nuclear region. So it does affect our seclusion order numbers. And again, we'll be going back looking at our post-data collection. And the poster completed, poster 17 by our colleague Anthony, will help when we go back to look at the post-data collection, because all the variety of nursing interventions are actually captured in the self-observation scale that I mentioned briefly a few minutes ago. We look at our patient satisfaction surveys, and when Ethna was talking this morning, and Caroline, and we were looking at the metrics, the traffic light system, I think, just looking at our results, the traffic light system, I think we'd be certainly amber and maybe red in lots of areas. But again, it's work in progress, and there's a lot of areas that are very, very complimentary about staff, say in relation to the care, overall care. There was 22 questions, sorry, I should have said that, and 11 patients surveyed, and it was a combination of Assure, service user, rating effectiveness survey, and a combination of the Mental Health Commission's patient satisfaction surveys. There was 22 questions, and questions in it, and there was 11 patients surveyed. There is a variety of results. As I say, some of the areas are quite high, probably from the traffic light system, they'll be up in the amber. I don't think any of them will be in the green, but there will be some of them from a psychosocial point of view that we can go back and certainly do more work and do more training and more support and clinical supervision. And when we go back and do the post-data analysis, patient satisfaction analysis, then we would love to be able to come back here and show you that they're all in the green. There's some of the other questions that were there. Say again, in relation, pulling them back in relation to psychosocial interventions, 44% said the benefits and the side effects of the medication are explained to them. Activities or discharge planning or whatever. So there's areas from a psychosocial point of view, from all patient satisfaction point of view, that we certainly need to focus on, and that hopefully the new unit, the developments in relation to the training program and the ongoing support and clinical supervision, that we'll see a much greater improvement when we come back and look at the post-data analysis. We looked at the charts, the nursing documentation in relation to care planning process. We were guided by, the review was guided by the NICE guidelines for schizophrenia, and we analysed the data using Roland Clark's phased thematic analysis framework 2006. We reviewed as the 10 charts, which is a third of the patients that were in the units at the time. And the emerging themes, again, fitting them in with psychosocial interventions type approach, was just the engagement and management of therapeutic alliance. And we added anything that was even written in the documentation of the care plan, even once, we added it into our review, our analysis. So the type of things that were coming out was, again, this is pre-data, reassuring the patient, talking to the patient, observation and close observation came up quite often, one-to-one engagement, taking patient for walks and monitoring mood. Biopsychosocial assessment, there was nursing assessments, but risk assessment was probably the most common things that was mentioned. Stress management, problem solving. Yes, nurses were identifying using relaxation techniques, distraction techniques, deflection, removing from the area, step down and time out. Medication adherence strategies. There was a lot of talk about medication management, use of psychotropic drugs, and the use of PRN medications. And in other interventions that had a large amount of data input in the nursing documentation, was talking about diet, sleep, hygiene, visits from families, and money management, which was very clear in the documentation. And there was reference to using seclusion. If we go back and look at our post-data analysis, which we have completed, with 4 charts, again, it was a third of the patients that were in the units at the time, because the numbers were reduced. We used the exact same process. Our review was guided by the guidelines for schizophrenia, and we analysed using Roland Clark's thematic analysis. And the emerging themes. Again, engagement and management of therapeutic alliance, there was a lot of talk about reassuring the patient, how they reassure the patient, talking to the patient, observation, close observation, one-to-one engagement, taking patient for the walks, positive reinforcement, monitoring mood, and de-escalation techniques. Biopsychosocial assessment, entries around risk assessment, independent living skills, Many-Mental and Glasgow Antipsychotic Scale, which again was an increase of psychosocial approaches. Stress management, problem solving, and coping mechanisms. Staff talked about relaxation techniques, distraction techniques, deflection, removing from the area, step down, time out, and encouraging ventilation of thoughts and feelings, which again we would be encouraging from a psychosocial point of view. Music therapy and art therapy, and these were all things that were carried out by nurses. Medication adherence strategies, educating patients on the benefits of medication. So we were delighted to see that coming in there as well from the point of view nurses talking about educating their patients, talking to their patients about the benefits of taking medications. Other interventions, again, a lot of interventions written about diet, sleep, hygiene, visit from families, and money management. Psychoeducation and relapse prevention. We were delighted again that nurses were wellness recovery program development. There was talking about family interventions, encouraging family meetings, working with families, talking to families about their relatives' illness, and explaining the diagnosis to patients. and there was elements, seclusion was mentioned as well, obviously, in the documentation. Just looking a bit, before I go on to the conclusions, support, I know I've said about the monthly meetings already in the support group, but again, and I know Professor Scott mentioned it this morning, about it's so important to have managerial support, both from an assistant director, directors of nursing, directors of nursing, and clinical nurse managers. It's vital that if we're looking for a change in practice and we're looking at a change in the cultural practices that are involved from a mental health nursing point of view, we need to be able to support them. We need to be there on a regular basis providing that support. The introduction of clinical supervision. Yeah, our records, we have, we now have protected time clinical supervision that's available. It's a slow uptick. But again, we constantly review our promotion is encouraging people to take up clinical supervision. And the 3 people who started the PSI program, the psychosocial intervention program in Connolly, they had mandatory clinical supervision, which again would help to embed everything that they're learning from an educational point of view and from a practice point of view, that they would continue on. And all of the literature would say that in relation to embedding changes in practice. We've online assessment packs on units and staff who did the program would be familiar with these assessment packs and will be able to use them. We have a coping assessment skills enhancement case packs, which are just decks of cards in relation to teaching the patient how to cope, whether it be to cope with hearing voices, whether it be to cope with anxiety, or whether it be to cope with depression. They're very simple, they're very user-friendly, and again, it's probably one of the areas that we think it's going to take off, because, you know, staff, it's something simple to start off, and very effective. The introduction of the SOAS, which I've already said, which gives us all that vital information about what else are nurses doing. You know, the nurse does not place a person in seclusion until it's an absolute last resort. And the documentation, in the current documentation, didn't always pick that up. So now with this documentation that we have, we're able to go in and we're able to look and say, yes, you know, nurses are, you know, the variety of interventions and strategies that nurses are using before they actually have to do it. And as I said already, the 3 participants completing the Level 8 certificate in PSI, which is great. Our ongoing plans, we have to complete our post-evaluation data analysis. And go back to again what Professor Scott said this morning about the training and development in relation to nursing managers and assistant directors of nursing. We think it's vital. You know, if you expect people to change their practice, everybody has to be able to support them. So there's absolutely no point, you know, Gertie or myself talking about psychosocial interventions if everybody else doesn't know what we're talking about as well. So all the clinical nurse managers, all assistant directors of nursing and our directors of nursing, you know, that we would have, everybody would be speaking the same language and supporting the practice, the change in practice. And when I say review of nursing documentation, we need our nursing documentation needs to be more collaborative, and we'll probably focus anyway. But we also need to zone in a little bit on what nurses are writing and how they're articulating the care that they're giving. Because we know from walking in and out of the units and observing nurses from a mental health point of view, we know that they're doing a very, very good job. But again, like a lot of, you know, talking to a lot of my colleagues, in practice development, you don't always see that. It's not reflected in our nursing records. And even though it was encouraging to see that, you know, there was some element of psychosocial interventions in the nursing records, the majority of what's been written in our nursing documentation at the moment is about the fundamentals of care, which obviously are very important. I'm not saying they're not important, but from a mental health point of view, we should be writing more about our engagement and our interactions and the conversations and the helpful conversations we're having with our patients, as well as all the other things. And I think if we were to take a lesson in what we should be writing, you know, I had things up there like about taking patients for a walk. And if we want to get a lesson on how to write about that interaction, we should look at some of our other disciplines, the way they write up about taking a patient for a walk. And maybe I'm talking, you know, about maybe our occupational therapists. They can articulate something as simple as going for a walk so well and so beautifully that we as nurses need to be able to do the same thing. And this is one of the things that we aim to do in our continuation of our research. So in conclusion, there was some evidence of the use of a variety of psychosocial interventions. The only thing is we would identify that there was 2 or 3 key nurses. So go back to, I think we said 43, they completed our program. And yet when we were reviewing the documentation, it was very clear, or we could actually pick up, that the main psychosocial interventions that were being written about and recorded and actually in the plan of care for the patient were being done by 2 or 3 key nurses. But that's good. We're just going to go back and we're going to build on that. They're going to be our champions. We're going to, promote that and encourage that and get more people doing more. Nurses did express at the support meetings that their lack of confidence, and this would be consistent with all the research in relation to psychosocial interventions, that we need more. We need more development, we need more practice, we need more support, all of that. I think it's not that people don't want to do it, it's just the lack of confidence, especially around the whole area of behaviour therapy, and maybe cognitive behaviour therapy, and maybe some of the assessments. So that's something that we need to look at. There's also a notion of reduction in the use of seclusion. However, we do think it may be attributable to the environment, but also we have to acknowledge the efforts of staff, and also now that we're going to have more details in relation to the interventions that nurses are using through the introduction of the staff observation aggressive scale. We need to continue to support people to take up clinical supervision. And we have done a lot of promotion work, but again, there may be this, fear or anxiety of people, haven't been, barging down our doors. We're not all inundated with participants looking for clinical supervision. It's slow, and it's there, and we're going to continue with it. We're going to continue to promote the culture of nursing practice in relation to PSI. We know we have a really dedicated, expert group of staff working in the people unit. We know that. But what we do need to do is enhance and develop their skills further and to support them to actually do, or to make psychosocial interventions as part of their daily routine. But to do that, then we need to start looking at some of the other tasks that people are doing. And I know Professor Scott again mentioned this morning about all the non-nursing tasks that people are doing. So that's another area that we're going to be able to look at. And looking at developing CNS posts and advanced nursing posts in the PICA unit. Sorry, that's it. Thank you.
Thank you very much to Melda for the very positive presentation there of the impact of an alternative wider range of interventions in patient care. Moving along, I'd like to invite Dara Roger to make our next presentation. Dara is a registered advanced nurse practitioner in care of older adults in the community. And Dara is involved with education in the clinical and academic setting, and also to local community groups on different aspects of healthy active aging. Dara is project lead on bone health in the Park and Forever Autumn Community Practice. She's a member of Healthcare International Society of Ireland Nursing and Midwifery Special Interest Group. And she's on the management committee of the All Ireland Gerontology Nurses Association and is currently joint chair of Affinity, which is activating fault and fracture prevention in Ireland Together, education and learning support team. Dara will present this afternoon a study in relation to informal carers' experience of caring for older adults at home.
I know it's been a long afternoon, so I won't keep you too much longer. As Anne-Marie said, I'm going to talk this afternoon about a study I did on the informal carers' experience of caring for older adults at home. And that's just this afternoon what I'm going to go through. And I think it's quite apt that I'm talking about this and sharing it with you today, as this is National Carers Week. I'm not sure if many of you are aware of that. And by their latest figures released this week in the news, there's 187,000 documented carers in Ireland, and that's from the 2012 census. And recently I was at a symposium on carers in Trinity, and Eamon O'Shea, who's a health economist in the Irish Centre for Gerontology in NUIG, he estimated what the total budget for older person care that it currently is across the care spectrum, and that would be from hospital, outpatient, primary care, home care, and residential care, and he estimated that to be about 1.2 billion euros. Now, informal carers are, as we know, unpaid, but he said if we were to cost the amount of hours that those carers carried out, it would be next to 800 million euro added to our budget, so that you can see there that they are invaluable and they need to be recognised. So the rationale for the study, I worked in an outpatient service offering urgent assessment to unwell older adults in the North Dublin area. Most of it then were not known to any services at all, and they may have attended their GP, other than that they didn't attend the geriatrician services, and the majority of them would have been aged over 80 years. Quite a number of them were dependent on care provided by family carers with no formal recognition to their role or what the needs they may have. And they didn't identify themselves as carers when they came to the clinic. They came as the husband or the wife or the daughter or the sister or the family member. But yet they were providing a significant amount of care. A lot of them had been providing this care unbeknownst to anybody else, and they were already struggling, and healthcare professionals really need to be aware of carers and help them on their journey. And often the care needs of the carers are actually quite complex, and some of them are providing care up to 24 hours a day, 7 days a week, and they would be the ones who are looking after somebody with maybe dementia or Alzheimer's. And a lot of them have little or no supports. That just gives you an idea of why I did this study. We want to find out how can we support them. And number one is identify and recognise the role of the carers, to identify the needs of the informal carers, because they are quite vast and sometimes quite complex. And a lot of those who attended the service came because they were at a crisis point, didn't know how to manage, went to their GP and looked for help. So we want to try and avoid that crisis and maybe meet these carers, you know, at the beginning of their care journey rather than at a crisis point. So just looking at the background, the literature review, I looked at 24 studies. 3 of them were quantitative, 2 mixed quantitative, qualitative, and 19 qualitative, of which 10 were hermeneutic design, which kind of looked to get a better understanding or detailed understanding of the phenomena being studied. It included several studies from Ireland, the first study being back in 1988, which is quite timely in that the gerontology only became a speciality in its own right in Ireland in 1978. So be looking at older person services in 1988 was quite good, and this study actually informed the Years Ahead policy of the elderly in 1988, which was the first time that respite care and home care was kind of looked at. In Europe, in 2003, there was a study that was carried out, and that was over 17 countries. And they also looked at carers, and mainly because of the change in society, and the women traditionally being at home are now starting to go out to work. The family structure was changing, and there's going to be an obvious rise in costs for the government to see how these additional supports are going to be put in place to support family carers. So we need to carry out studies to establish that. And interestingly, the study, I put this one up here in the Lebanon in 2007. In the Lebanon, caregiving was seen as a source of enrichment and an act of gratitude towards the older person. But again, their society is changing, their family structures are changing, and as a result of this study, they recognise that carers are clients of health and social care, and they should be given support and helped along that journey. And it actually was opened the door for further studies in that area. So just looking at in Ireland then, what was the prevalence of informal caregiving? The 2006 census told us there was 160,000, nearly 161,000 undocumented unpaid carers, or documented unpaid carers. And as we've seen from the latest figures, that's now come to 187,000, and that's in a short period of 6 years. Our aging population is currently 11% of our population is over 65, and we have, I think, 30,000 nursing home beds. The aim of the government is to have only 4% of our adult population, our older adult population, in care, and the rest of the care being provided in the community. in 30 years when our population of over 65 is going to be 22%. It'll be double that number, and 70,000 nursing home beds is not going to be sustainable. So we have to start looking at how we're going to support the care in the community where the majority of this care is going to happen. What the census also showed is that in the Dublin area alone, we've got 70,000 documented unpaid carers, and what they're providing is 19% of them are providing 6 hours unpaid care a day, which is quite a lot. And this phenomenon it's global. It's not just contained to Ireland. We have some of the studies that I looked at were from the United Kingdom, Europe, America, Australia, and Lebanon. So it is a global phenomenon. And just going back to that there, a lot of these studies also recognise varying levels of carer stress, physical and emotional burden, sense of loss, time, relationship, inability to cope, loneliness, need for social supports, the need for increased awareness of available supports, understanding of need to accept supports that were offered, which actually was a big thing. Carers tend to not want to accept help or feel it as a sign of their failure in their role. Needed education on the caring role, need for recognition of their value as carers by healthcare professionals, and also for a caregiver assessment. So these are topics that came up in a lot of these studies. So what I wanted to do was then explore the experience of former carers who care for and maintain older adults at home. And my objectives were to identify who is caring for older adults at home, to identify what is the age profile, because our older adults are getting older, and if it's traditionally it's the husband or the wife or the sister who's looking after them, they're actually getting older too in a similar age group. I wanted to identify what is the health status of the carers. So again, if they're a similar age group, they're likely to have their own healthcare needs. I wanted to explore the experience of informal carers and ultimately then to make recommendations for practice. So the research design choice was qualitative, methodology was phenomenology, taking Heideggerian hermeneutic approach, and this aims to give not only to describe the lived experience of the older person or the carers, but also to get an understanding of the meaning of those experiences within the context of their everyday lives, in the caring role. So the data collection was through an unstructured interview. So I had 2 or 3 guided questions to start with, and that was to reach the objectives that I set out. I wanted to know what the age profile was, I wanted to know the health status. So they were 2 or 3 questions I asked, and then it was tell me your experience of the caring role, and that just opened the conversation then. The population was informal carers of older adults, and the sample size was 6. The inclusion criteria was they had to be in the caring role for a year or more, and so the exclusion was if they weren't in the caring role. So this was the profile of the participants in the study, and you can see their relationship. We have 4 daughters, a sister and a wife, and if you look at the age profile then, we have 3 of the carers actually older adults themselves, 70, 77 and 80. And then we look at the age of the person they're caring for them, and they're like the older 93 being the oldest. There was one person, one of the participants, who had poor health, and she was a sister, and you can see her age group there, 77 years of age. And 2 of them lived with the person they were caring for, so it was 24-hour care compared to the other 4. So for data analysis then I used Morse's framework, which is a 4-step framework. The first stage, comprehending, and this allows the researcher to make sense of the data, get a feel for what is going on for the participants. This stage familiarises the researcher with the data, and it continues until the research has gained all the experiences of the carer from the data. And this is achieved by the reading and rereading of the transcripts. Synthesising stage then. At this stage, the researcher becomes immersed in the data, which enables them to get a feel for what is going on, and is described as the sifting part of the analysis. It's the point of the research to identify what is the norm for the carers by what is evident in the data. and for many of the participants. And they're gaining some understanding of the variation between the behaviours of each participant. And the theorising stage, this is regarded as the sorting phase of the analysis. It's the essential tool, and without it the results would be without structure and could be very disconnected. And it's at this point then where the coding comes into play and themes are identified and sub-themes also. The recontextualising phase, then that's the point where the development of the emerging theory can be transferred to other settings and other populations of similar standing. And the goal of the recontextualising is the ability to place the results in established knowledge and to clearly identify those results that support the literature or claim new contributions. So from the analysis then, the key findings are presented under 4 themes, and the 4 themes that I came up with were from the data was time is not your own, wouldn't have it any other way, being the one, and support networks. And I'm just going to show a few different of the narratives from those 4 themes. Time is not your own, that was a big theme throughout all of them, and some of the the strain and the emotional burden and that I mentioned earlier, you can see how they could come into this with the time is not your own. Tied down, you're tied down so much, yeah, it's just 7 days. It's not yet, you have no day off, it's very frustrating, so it's constant ongoing for them. I don't mind looking after her, she's not a problem. I suppose the usual that you were tied, it's like having a child in the house, so it's like not being able to do anything or go anywhere, it's to have to be there constantly. There's no me time. Life revolves around my mum, that's what it is. Everything, every day revolves around my mum. So she has her own family, she comes over every morning, this lady, to her mother, but it's every day, her plan is around her mum, not around her own family. So she's missing out on her own family and her own time to herself. Time consuming. I'm there from one lady, she was there from 10 AM to 1 until the home help came in. And who was there to 2:30, so she got that bit of time off. She goes back down then from 2:30 to 5. The time is just gone. I go back down at night again. Her brother used to come in from work at 5 o'clock, so it gave her time to go home to her own house, cook her own meal, to look after her own things there, and then she's back down that evening to get her mum to bed. So you can see the time-consuming nature of it. No time for her own family. And again, the same participant trying to run up and down looking after her mum, trying to even have some lunch, sit down and have a bit of lunch on her own, or even to get some shopping done. It's just a constant time has been used up. And despite all that, this team was quite, I suppose, surprising, wouldn't have it any other way. Like, in one respect, they were nearly apologising for saying they had to spend so much time doing things, but at the same time, they wanted to do it. And the sub-themes that came out here were duty of care. She's my mum, she's the main person, and that is the way I would look at it. So despite even the hardship of trying to juggle family with caring for her mother, she wouldn't do it any other way. This is the way she wanted it. It can be tough at times, you're just not free to go anywhere, but at the same time there's nothing you wouldn't do. You know what I mean? You wouldn't have it otherwise. So again, they really want to do this. For participant F, this lady is looking after her husband with Alzheimer's. It's difficult, no doubt. What can I do? What can I do? I just keep going. It's her husband, she's a duty of care to her husband, so she needs to keep doing it. And you know, what we find as well was a lot of the time the caree doesn't want anybody else coming in and expect the carer to do all the work. She's my wife, can't she do it? We don't need anybody else. So you get that quite a lot. The need to do it was another thing. I think in the future I will never regret it, you know. I wouldn't see her any other way. So it's like I'm doing this for my mum while I can do it. It mightn't be too long. You know, this particular lady, the daughter for her mum, she was saying like it won't be too long, but actually her care process lasted 3.5 years. It was quite, towards the end it was quite hard for her. Who else would do it? This participant was looking after her sister, who never had any family, so there was nobody else. Her husband was dead 10 years, so she was concerned for her, so she felt she had to do it. And participants see this lady was 77, her sister was 87, had her own health problems, actually cancelled going into hospital to have a pacemaker fitted because who was going to look after the sister while she did it. So from this coming up on the study, we were able to arrange a respite for the sister so she could go and look after her healthcare needs. I will do it as long as I do it for me, you know. When I go up, even though I'm going up for my mum, I'm doing it for me. So it's again, she'll be able to say in the future when her mum's gone that when I did this for her. Being the one, this was quite strong, came out quite strong in it. A lot of the carers didn't choose to be carers, they fell into the role. They were either going to and from visits to the doctor, to the hospital, and then before they knew it, they were doing that bit extra and that bit extra. Again, they fell into sub-themes here. We have the main carer, she tends not to let my sister do anything for her. Participant B had a sister who lived 5 minutes away, but the mother just wanted her doing everything. She gets so upset, so you can't say too much, it's part of the problem. So even though they might arrange for the other sister to do something, the mother doesn't like it, so again it's put back onto her, and she feels that she's the one. Loss of relationship came into it quite a bit as well. For participant D there, I like going up and looking after her. The time I'm with her, I'm washing her, dressing her, feeding her, washing her clothes, making sure everything is adequate. It bothers me sometimes that I can't sit down and spend quality time with her. So she's going up doing all these tasks for her and never gets a chance to sit down and have quality time. She did have quality time with her when her mum had a bad urinary tract infection and she was admitted, and she called over to me in the clinic one day and she said, it's great, I'm up, I can have a chat with my mum, I'm doing her nails, it's lovely. And that was because her mum was in the hospital, she got to be visited for a change. And she would have had a big family who would have come and gone and been the visitors, but she was expected to do it, and she wanted to do that for her. Health status again came into it. I just keep working, doing things in the house. It's exhausting. I walk away. I walk into another room, go upstairs, but it still leaves me with a headache, but with difficulty. And this is participant F looking after her husband, where he keeps asking her the same questions and he keeps following. She can't cope with that, so her way of doing it is walking away, going in and out. So she never actually gets to sit down and have a rest herself. Even she went out to the back garden to hang clothes in the line, where are you? You should have been here. And she said, I was just outside. And it can cause problems there, which she finds quite difficult to deal with. And again, this gentleman didn't want anybody else but her, so you can see where the strain can come in. I wasn't able to with my own health. I felt so guilty because I wasn't doing more. I really wasn't able to do more. And this is the lady who had the pacemaker who we arranged. And again, the sense of guilt here that she wasn't able to do it, and it was because of her own health problems. And then the final theme that came up was support networks. And this we divided into two, in family supports and external supports. And again, for participant F there, I got to go to Mass every night in Lent because my son would be there. I found that absolutely great, to go out, to walk to the church, just talk to myself and walk back. Thank God, you know. And that was her escape, and that was, you know, just for Lent. Usually, you let her do that. The son lived in the house, but he came in, he came in and closed the door and didn't want to know. He couldn't cope with it either. But for Lent, he came out of the room and let her go to Mass, and she got great value out of that. But that was the only family support that she got there. Participant D, the sister came to visit, and she said she plucked up the courage to ask her, would she do something? She said, yeah, I'll come up on the Tuesday. And then she didn't come up on the Tuesday, so she said, what's the point in asking? So again, she didn't feel there was good family support there. Participant D then, my two sisters are very good support. They're always there if I need them for longer times. For holidays, one of my sister comes when I'm going away, which is great. So she might get a holiday, but the sisters are there and they're nearby, but they don't see themselves as being involved in the care role on an ongoing basis. It's all left to one person. Then with the external supports, we had a public health nurse once a week for the leg ulcer, but didn't find them any support because they're just too busy, as I felt you couldn't call on them. And then for participant D, our district nurses, they're very good when needed, they are good. I only need to call them and they come. Like she has an ulcer at the moment and she comes 3 times a week. And there seems to be this perception that within the group that the public health nurse is there just for the task, just for the ulcers, you know, and not there as a support. The feeling has to be a specific problem to call on the nurse, on the public health nurse. And this can be due to the lack of information and education being given to the carer and the caree. And earlier on we talked about education was one of the main things, that family education, patient education and planning for discharge are the 2 main things that are, you know, were deficits in the metrics. A lot of these people wouldn't meet the public health nurse at all, you know, normally, and this is our opportunity as healthcare professionals to give them information on their carers, on their role as carers, and to help them along. And if we're not doing that, you know, we're failing in our duty to them. And there's also, of course, the reluctance to accept outside support, seen as a failure on their part of the carer to provide the care themselves, and also that guilt. And then the caree sometimes doesn't want any outside support coming in at all. So then the conclusion that the research recognised that informal carers are essential for the continued care of older adults in their own home. And the role of the older adult population will be their role needs to be acknowledged. It's proposed that no more than 4% of the older person population should be cared for in residential units in Ireland, and that's the Department of Health in 2008. And as we know, with our ageing population, 4% of our population is going to be double what the population is now in relation to those requiring long-term care. There's reluctance of family caregivers to use the services for which they are eligible is highlighted, as is the preference for carers to solve problems on their own, which presents challenges to those trying to provide services to family carers. And sometimes we've even been in the hospital and they're going home, and it's recommended that they have home care packages or have home help. The families are resistant to that. So we need to provide more supports and education to family carers, and this will go a long way towards improving the quality of life of the carers. The study has identified that there are inconsistencies around the carer's role and how to access and when to accept help. Halberg there noted how very few services provide family-oriented approach, including supports and education for informal carers, and also to take the whole family into the picture when they're looking at the role of the carer, not just the person who arrives at the clinic. So everybody has a role to play. With our ageing population and the increase in disabilities in later life, this study and its findings are timely to support the development of formal supports for informal carers. So what are the implications then for practice? Well, we need to have a more structured support network across the care continuum, whether it be formal or informal, and at the moment that still doesn't exist. It's very hit and miss in areas, you know, when the older person comes into the medicine for the elderly services, it's timely, it's very good time to bring up the whole subject of care, and are you providing care for this person? Can they do everything for themselves at home? If not, how much are you doing for them? So it actually gets that dialogue going from the very early stage. Education needs to play a major role in care provision, informing carers on all aspects of the care role relevant to their individual circumstances, so we need to work on that. And then also the care assessment at the beginning of the care journey is essential, and I know the new documentation for assessment of older people that has been included in that, which is good. And the important thing is that for the cycle of care to exist, we have to break that to include the healthcare professional as part of the wheel, so the carer doesn't feel alone and isolated, because we have a duty of care to people, our patients who are being cared for at home by informal carers who are under a lot of professional stress. So we need to do something about that. And
Thanks very much to Dara, who I think very well encapsulated the real and everyday challenges facing carers and older people in the community. Our final speaker this afternoon, I'd like to welcome Professor Graham Smith. Graham is Professor of Nursing in the School of Nursing, Midwifery and Social Care of Edinburgh Napier University. and he has been a Fellow of the European Academy of Nursing Science since 2003. His doctoral studies at University of Edinburgh arose from an interest in psychological care in gastroenterology. He then worked as a senior lecturer in nursing studies in the University of Edinburgh for 15 years. He has studied health-related quality of life issues in patients with a variety of chronic illnesses. His current research interests include the use of medical hypnotherapy as treatment for functional bowel disorders, and he's currently working with a group of Asian academics on a collaborative project to examine psychological morbidity in chronic disease. He's editor of the Journal of Clinical Nursing and has published textbooks on nurse education and gastrointestinal nursing. This afternoon, Graham will present an overview of issues of complexity in nursing research. Very welcome.
Thank you, Anne-Marie, and thank you very much to Linda and to Ethne for a kind invitation. As always, the hospitality in Ireland has been wonderful, and I'm very pleased to be back here. This afternoon, I'd like to speak to you about complexity in nursing research. I would like to base my lecture on cardiac nursing, and I'm very pleased to see a cardiac nurse in the room. I should state that I'm not a cardiac nurse myself, but I'm going to talk about it from the perspective of some of the work that David Thompson has done in relation to cardiac rehabilitation. That's just going to give the background to complex interventions. The main reading that relates to the lecture that I will give this afternoon relates to two papers that I published myself looking at complementary therapy and complexity. But what I wanted to do was to make it more focused to the nursing profession. And I think that cardiac nursing lends itself very nicely to complex interventions. I could have chosen several topics. This afternoon we've talked about psychosocial interventions, which by nature are very complex, and other presentations that I've heard today in relation to pain management as well, always present themselves with a complex nature. So the two papers I want to refer to, one is complexity in nursing research and complementary therapy, and the second one relates to consensus and complementary therapy methods in nursing research. So for anyone who wants to do additional background reading to this lecture, those papers I think give most of them to you out. Medicine and healthcare changed dramatically in the 1990s with the event of David Sackett's paper on evidence-based medicine. And I'm sure we're all aware of the importance of evidence-based. Professor Scott this morning talked about the importance of evidence-based in the nursing research in relation to the development of the nursing profession. Historically, evidence in medicine may come from consensus. Doctors used to sit in a room together and decide whether and what was the best approaches to care. Thankfully, now we take a much more scientific perspective. I'm not sure how clear the pyramid that I show here, but there's the evidence-based pyramid. And at the top of that pyramid, we see what is seen as the best evidence. Systematic reviews. These are reviews that pull together the randomized controlled trials, the gold standard of experimental research designed together to give us the best evidence. Nursing and nursing evidence is important also, but sometimes nursing research doesn't fit nicely into this pyramid. Often it's difficult for us to conduct randomized controlled trials, and often areas of nursing research don't fit nicely into this model. So what I want to do this afternoon is to share with you my perspectives on complex interventions, my perspective on how nurses design research projects to overcome some of the complexities that we face. So the background to this lecture is that complex healthcare interventions are common. In fact, I would argue that most nursing research is complex in nature. The nature of nursing itself lends itself to complexity. It's often even difficult to define what we mean by nursing, let alone describe a nursing intervention and to try and define it. These complex interventions have multiple, interdependent and interrelating components. Evaluating effectiveness can be problematic because sometimes it's difficult to define the components. If we're providing holistic care, there will be physical components, social components, psychological components, and all of these need to be defined to get the full picture. So in general, we have got complexity in nursing interventions. I mentioned cardiac nursing, I mentioned David Thompson's name. I think that cardiac nursing is one area, or aspects of cardiac nursing, such as cardiac rehabilitation, is one good example of complexity in healthcare. I don't claim to be a cardiologist, but I do know that people who've got cardiac problems often end up in hospital, having surgery, having surgical interventions that may lead to other forms of investigation or other interventions, which may lead to taking medications, being put on cardiac rehab programs which may involve exercise, and may involve advice around diet as well. A full range of treatment processes, which I'm sure you would agree with me, would be very difficult to evaluate in itself. So, what are the aims when we want to look at this? Well, we want to identify key questions when we evaluate complex interventions. We want to identify methods for evaluating complex interventions, and to do that, I'm going to share with you the commonly used Medical Research Council framework for developing and evaluating complex interventions. Originally released in 2000, updated in 2008, written for medics, but with a clear implication for nursing and nursing research. And hopefully, through introducing that framework, we may understand some of the complexities in a position to deal with some of these complexities within nursing research. So what will I cover in this lecture? Well, I'll give you an initial overview to the original 2000 framework, the development and evaluation of randomized controlled trials for complex interventions. I will then move on to the 2008 guidance and make specific links to nursing research before giving descriptions of complex interventions. What is a complex intervention? Well, I've already stressed that I believe that a lot of nursing research is complex in nature, and then by definition, complex interventions are very difficult to define. They're built on a number of components. As I've said already, these components can act independently or interdependently, and these components usually include things like behaviours, the parameters of behaviours, like the timing and the frequency of care, the delivery of behaviours such as the setting, and the role that the practitioner plays in the delivery of care as well. There's kind of a continuum when we look at complex interventions. At one end, the simplest end of the continuum, or the simplest end of the spectrum, is the traditional randomized controlled trial for a drug. You all know that when drugs are tested, the usual protocol is to test the drug against a placebo. We do it by randomized controlled trial. If we've got a big enough sample, if we've got control, we've got appropriate randomization in place, we can make an assumption on cause and effect. It's not so easy when we're trying to evaluate the role of a clinical nurse specialist, delivering several aspects of care, but providing a very important service. So when we look at clinical nurse specialists, or when we look at things like stroke unit evaluation versus conventional care, I'm quite sure you would agree with me, it's quite complex. If we want to define whether an intervention is complex or not, we want to ask ourselves, is it easy to define the active ingredients of an intervention? Often people speak to me about an intervention having an X factor, a specific factor within it that influences the outcome. And I want to use the example of stroke units again. Research shows that stroke units work, I think, across the world. Wherever you are, people will talk about the benefits of stroke units and the multidisciplinary approach to care of people with strokes. But what exactly is a stroke unit? What are the active ingredients that make it work? Is it the physical setup? Is it the mix of healthcare providers? Or is it developments in technologies and the technology that's available? And again, the word complexity comes out when we think of this. So we see, in this instance, someone in the early stages of the stroke unit, very technical scenario, and as time moves on, those medical techniques move apart, and we move into things like counselling and rehabilitation, which is much softer. Now, often people say to me, why should nurses be interested in complex interventions? Why should nurses be interested in the Medical Research Council framework for evaluating and defining these? Well, I believe that nursing interventions, you need to know the effective components or ingredients. I strongly believe in the role of clinical nurse specialists. I've been really pleased today to hear clinical nurse specialists talk about their role and the impact that they make in their role. But I think it's only by defining that role and understanding that role that we can really understand the true impact. Effective interventions would not be implemented without these sorts of roles. So the cardiac intervention that was talked about this afternoon, which could really save money, improve patient quality, would not take forward if we did not put it under the research microscope. We may conduct studies with inadequate preparatory work, and this is a big problem across all of healthcare research, doing adequate preparation before you start the work, defining the research question, identifying the knowledge gap. So we want to ensure that the interventions are effective in practice. As I've said already, the Medical Research Council framework was designed in 2000 as a framework for development and evaluation of randomized controlled trials and complex interventions. So by the fact it's looking at randomized controlled trials, it's very experimental, very quantitative in nature, and I will come back to how that has changed over the years in subsequent slides. The Medical Research Council think that the harder it is to precisely define the active ingredients of an intervention and how they relate with each other, the greater the likelihood it is a complex intervention we're dealing with. And once again, like a stuck record, I will say in nursing research, I believe often complexity is present. So they produced this framework to recognise unique challenges evaluating developing complex interventions. They highlight potential strategies to overcome these challenges, and they provide a stepwise approach, not required steps as in consort, which gives us clear guidance in relation to transparency in the reporting of experimental designs. I greatly encourage people here who are developing studies, who are looking at moving towards developing doctoral studies, to become familiar with this framework, because I think it gives very good guidance, and I think very quickly it will become a good friend for you. The initial 2000 framework had 5 distinct phases. These stages may take place simultaneously, but each of these phases can be seen as quite distinct. The pre-clinical phase, that is the theoretical work that's done before a study starts. You may remember I said earlier that often research can start with inadequate preparation. So it's important that we have a theoretical background. That moves into the modelling stage, the designing of your study, the design of your intervention, whether it's a pain management intervention, how that intervention is going to be rolled out. The Medical Research Council greatly encouraged people to do exploratory phase trials. Exploratory phase trials aren't that different from pilot studies, but they allow this intervention to be tested for applicability, for feasibility, for acceptability, and then it moves into the definitive randomized controlled trial, often seen as the main study, moving on finally to long-term surveillance. So when a study is finished, we continue to monitor to see if there are adverse effects that may come over time. I'm not sure how clear this slide will come up, but this is the continuum of increasing evidence based on the Medical Research Council 2000 framework. So as I said, starting with theory, moving into modelling, the exploratory trial phase, moving into the definitive randomised control, and long-term implementation. I really encourage people to become familiar with this model, and particularly to become familiar with some of the early stages of this model. There's a lot that can be gained in nursing research from exploratory phase trial work. With time limitations this afternoon, I'm not going to talk in detail about lots of studies that nurses have done to look at specifically at the use of the framework in nursing research, but I'm going to make examples of 2 Irish papers that have come to light. One which was published in the Journal of Advanced Nursing in 2006 by, I think it is Beth Blackwood, and looks at methodological issues evaluating complex healthcare interventions. And this study looked at the weaning of patients off ventilators. And in the unit that this author worked, there was a nursing role in relation to weaning patients off the ventilators, and she wanted to define and evaluate an exploratory trial that looked at the nurse-led role in relation to this. Very briefly, skipping past the study basically, but what this author found was that this offered a structured format. Using the Medical Research Council format, identify the evidence, exploring the suitability in the local context, and enabled exploratory evaluation. So she had a very positive spin on the use of this framework, identifying constant and variable components of the complex intervention in relation to her study. She didn't do a full randomized controlled trial, but she did do some early stage work. I think I've probably stressed my positive feelings towards the MRC framework, but it does have implications, or it did have problems in relation to nursing research. It was highly influential in relation to medical research, highly influential in traditional pharmaceutical drug trial research, but it became clear as the years passed that more conventional and innovative methods had come along, and the guidance required revision and updated. It was released in 2008. There's a very clear web link to the Medical Research Council guidance. Within that web link, there is a lot of literature just is available on that web link, but there is one very, very good paper by Craig and colleagues in the British Medical Journal in 2008, and it summarizes very nicely updated revisions. I've also given some references here which are available on that website. So what were the problems with the original 2000 framework? Well, it was too linear. The theoretical and modelling stages were ill-defined. It didn't have any scope for research out with the randomised controlled trial. And as I've said already, nursing research often doesn't lend itself to the randomised controlled trial. We've heard this afternoon people describing very interesting and innovative qualitative studies. So the role of qualitative research was almost at the side. So the framework was modelled on drug evaluation. The assumption was that randomised controlled trials were the only option. The Medical Research Council realised that that was wrong and that they should be thinking more openly. So they developed and evaluated several phases and described those phases that did not require to follow a linear sequence. They said that experimental design was preferred, but there was room for observational design, and there was room for other forms of methods as well, like qualitative methods. They encouraged the use of mixed method studies as well. And this is good news to nursing because, as I've said already, it's not always practical in nursing to use experimental design if we're looking at particular research questions. They understood that processes were important, but does not replace the evaluation of an outcome. And the reports of complex interventions should be more detailed to enable replication and wider implementation. And I'm quite sure that you will be familiar with reading research papers, and often the description of an intervention may be inadequate to actually replicate the study that you may wish to replicate. So a lot of attention given to replication as well. So the summary points of the 2008 revision: complex interventions may work best if they're tailored to local needs. They do not need to be completely standardized. I personally live in Hong Kong at the moment, and what we're looking at is looking at self-management packages that have been developed in the UK and applying them in Hong Kong. Now, obviously, in Hong Kong, there's a different way that we live life. People eat very different food. So if you're having a cardiac rehabilitation program, the type of diet that you may put a patient on in Hong Kong may be very different to that you might put them on in UK or Ireland. So this new revision said there's scope for not being completely standardized. The reports of studies should contain detailed description of the following: the intervention to allow for replication, the evidence synthesis, and the wider implications of the intervention. Perhaps I should say wider clinical implications of the intervention. So this is the revised, less linear approach to evaluating complex interventions as advocated by the Medical Research Council. Feasibility and piloting, moving to evaluation, implementation, and development. And again, this is meant to be a far less linear approach that is more user-friendly to those of us who are engaged in other forms of research other than the randomized controlled trial. I'm going to finish today by talking very briefly about non-experimental approaches to complex interventions as well. I think it's important that we stress the importance of experimental design, but we need to be aware in nursing research, many of us are engaged in qualitative research as well. So there have been several very good papers. Lewin's paper in the British Medical Journal looked at non-experimental approaches to complex interventions. And complex interventions are difficult to assess by quantitative methods alone, in their view. Qualitative research can support the design of interventions, improve understanding of the mechanisms and the effects of interventions, and increase the number of randomized trials, increasing numbers of randomized trials which include qualitative components. So the role of qualitative research in complex intervention research is increasing, and many of my previously skeptical medical colleagues are now becoming more aware of the value of qualitative research in this area. Non-experimental approaches, such as just qualitative research, have often been carried out before a trial takes place. And Lewin saw this as an opportunity missed. Opportunities are missed to find out about the recipient's experience of the intervention, or often there are methodological shortcomings. The qualitative research is poorly integrated into the main study, it may lack rigor, it may not have transparency with it, and he highlighted several ways that qualitative methods should or could be integrated into nursing research. For example, before we design a study, it may be used to help generate the hypothesis for examination. It may help to define and refine the intervention. It may help to select appropriate outcome measures. Whilst the study is ongoing, we can find out whether the intervention is being delivered as intended. We can explore the deliverer's and the recipient's response or experience of the study, which would be very difficult to do via quantitative methods. And after the study, it can explore reasons for findings or explain variations and may potentially generate further questions. So I think there was a general acceptance of this change towards qualitative research being more important in this field. Richards and Bordlin in 2011 encouraged and urged nurse researchers to increase the volume of translational research by embracing these new complex research methods thinking. So we want to enhance translational research in nursing. We want to have impact of research, as Professor Scott said this morning, to generate that evidence base, to take nursing research to the next level. And again, I encourage you to read Richard's paper if you are interested in this area. Another paper which has recently been published in my own journal is again from authors in Ireland. It is looking at developing complex interventions for nursing, a critical review of the guidelines, and it provides a very interesting critique of the Medical Research Council guidelines and other guidelines that are available, but clearly focuses on the MRC framework. It examines approaches to developing complex interventions in nursing research and to develop and test interventions for evidence, and most importantly for us, for safe practice. If we've got interventions that we're developing, at the bottom, at the top of our importance list is the safety of the patients that are receiving those interventions. They did a literature review using systematic approaches. They found that the MRC framework was the most commonly used. They identified 14 studies that were very clearly complex in nature, and they felt that they aid the development of nursing interventions to help decisions made by the research process. And again, they were particularly important in the modelling and early phase testing of interventions. And again, this goes back to my point of people being appropriately and adequately prepared before they start a study. I think it's very important. And they developed a model to help nurse researchers. And again, Corey's paper, which was in press last year, I would encourage people to look at if they're interested and they're in the process of developing an intervention which may be complex. So I would like to thank you for your time this afternoon. I want to summarise today by just one or two key points for nurse researchers in relation to complex intervention. I believe that we need to improve the definition and measurement of complex intervention outcomes. I think we need to use research evidence systematically to develop interventions. So I stress again the importance of the theoretical and of the modelling phase of the Medical Research Council guidance. And I think we have to adopt relevant research design. And that research design should be dictated by the research question, and the research question should be developed in relation to knowledge gaps that are available in the literature. I think there are some issues with the randomized controlled trial in nursing research. I do believe it is still the gold standard of experimental research design, but I hope during this short presentation I've highlighted the potential role that qualitative research can play and the benefit of qualitative and quantitative research being together to provide the best outcomes. My final slide is again the importance of the evidence base. Following the Medical Research Council, one can generate the evidence that can take forward the nursing profession. I've been incredibly impressed by some of the presentations that I've heard today, and I hope that those presentations will go forward to be disseminated in publications. As an editor, I'm very keen to see some of those papers, some of this research in paper form, and I think that all of this will enhance research perspective of nursing. I'd like to thank you for your attention, and any questions that you do have, please feel free to send by email to myself. I'm very happy to take any questions.